Good afternoon, friends. It's an honor and privilege to welcome today's chief guest, Dr. Suchitra Pandit, guest of honor, Dr. Madhuri Patel, and Dr. Meena Samant. And I welcome all my esteemed faculties and dear participants. Without wasting, can you hear me? Is there any problem?
We can hear you, madam. Please go ahead.
Yeah, your slides are not moving. So without wasting much time, I would like to introduce our today's chief guest, Dr. Suchitra Pandit. Yes, Dr. Suchitra Pandit don't need any introduction, but just to highlight her achievements and just to make her familiar with today's audience, she is currently the sitting national president of ISOPAP. She is consultant department OBGYN Surya Hospital Group of Hospitals, Mumbai. She is a chairperson AICC RCOG from 2017 and she will continue till 2021. She is past president of Foxy ICOG. She is past president of Gestosis. She has represented Foxy to AOFOG. She was chair of SAFOG Medical Education Committee. She was president of Mumbai Obstetric Gynec Society. She was professor at Sion Hospital and she has participated and helped Foxy in preparing so many GCPRs. She has many awards to her credit and she has been secretary when she was secretary. Suchitra can't figure this out, but she is very passionate about adolescent health education and she has actively participated in the Kishori project of adolescent program of Foxy. Wow, mind-boggling publications to her credit, 125 publications. She has authored 5 books. She has been awarded 35 orations and she has won many prizes. She's a very good orator, a great academician, a friend, and a humble human being. I invite Dr. Suchitra Pandit to give her chief guest address.
Thank you, Lakshmi. Thank you. It's such a pleasure to be back here for the Vidarbha ISOPAP chapter. Such a vibrant chapter. I know since you have taken over, there have been so many programs, and I'm glad that you're trying to touch base with a lot of people and trying to create that awareness in their mind. So I think that's a wonderful thing that you've been doing. And I would also like to thank you for calling me this time, because I think now in the next maybe 10 days I'll probably be finishing and I'll be handing over to Dr. Usha Sharma. And of course, I'd like to say at this juncture that tomorrow we are inaugurating the ISOPAP Mumbai chapter, and on Wednesday we are inaugurating the West UP chapter. So, we have 2 chapters before I leave, and I just hope that Aurangabad also, takes it seriously and they start off with the Marathwada chapter after them. So, it's good because we want to see ISOPAB, the Indian Society of Perinatology and Reproductive Biology, grow and spread its wings. And I'm glad that's why that you've called, Dr. Meena Samant, who is a very vibrant General Secretary, and Dr. Madhuri Patel, amazing woman, because the way they have conducted the Foxy, Managing Committee meeting effortlessly yesterday. Lovely to be at that meeting and lovely to see both these ladies today. And the 2 very humble gentlemen, Professor Gangadhar Sau, who is my Vice President this year, and they will hopefully have, once the pandemic gets over, they will have their conference, which is due to them. And Milind Shah, of course, our past President of ISOPAP, whom I took over for. I'd like to just mention over here that we recently had an essay competition. COVID, how did COVID treat you, and what is your reaction to it? So I must say that both the people who won the prizes are here with you. Professor Gangadhar Sau has written a beautiful essay, and so has Dr. Prajna Mishra. She's also a part of your team today.
Yes.
Wonderful people. I feel that these should be up on the ISOPAP website. Meena, please put them up so that people can actually go through it. The real life heart, completely from the heart experience. Now to mention my dear Sneha Bayar, It's always so nice to see her because she's another dedicated person and has done so much of good work for the ISOPA chapter as well as for post. And of course, I welcome all the others, Chinmay Ratha, Charmila, Pragya, Dr. Ashok Kumar, Mitra Saxena, newly elected Secretary of ICOG, and Mitra Saxena for her chairperson's post. And I'm sure that this case-based discussion is going to throw a lot of light because Chinmay Ratha is again an authority on the subject. And of course, congratulations to you, Lakshmi, once more, and to your secretary, Rashmi, for having put forth this program. And I, thank all the viewers for being here at this time and enjoy the session because there are lots of things that we learn when we are doing the webinars. I was just remarking to Dr. Madhuri that there's so much of learning on the webinars. When you're actually in the hall, sometimes you're out having coffee or you're talking to somebody, but this is actually, intensive learning for a shorter period of time and you gain a lot more. And thanks to the Bharat Sera. Once more, thanks Lakshmi, and we hope to see all of you, in the immediate future for all the next webinars. Thank you very much for having me over.
Thank you so much, Suchitra, not only for accepting my invitation, but for your words of encouragement and appreciation. Because I knew that you are handing over on 4th of October, so you will not be there for the next webinar. So I am happy from bottom of my heart to see you here in the capacity of President ISOPA. We are there as a friends in all the forum, but here you are there in the national, in the capacity of President ISOPA. So thank you so much, Suchitra. Now I would like to introduce our guest of honor, Dr. Madhuri Patel. Those who attended yesterday's meeting must appreciate Dr. Madhuri that she was there for more than 12 hours continuously managing the show. And I must say that Madhuri has become a real IT person. I mean, you must have seen the Foxy website. She has done the changes in Foxy website. She has come out with Foxy app. Madhuri, wonderful you are doing for Foxy. She is currently the Deputy Secretary General of Foxy. She was Joint Secretary Foxy in 2009. She was committee member FIGO on the Committee of Preterm Birth. She is holding so many posts. She is Joint Associate Editor of Journal of Obstetric Gynec, Jogi. She is Honorary Clinical Associate at Wadia Hospital, Mumbai. She is consultant at so many places you can see. She has been awarded with MOGS Mrs. Shailaja and Mr. Narayan Pandit Award for the year 2019-20. She has delivered guest lectures at many forums. She has delivered orations. She has more than 50 publications to her credit. And I invite now Dr. Madhuri Patel to address the audience. Dr. Madhuri. Madhuri, are you with me? Huh. Yes. Unmute yourself.
Yes. Yeah. Thank you, Dr. Lakshmi, for your kind words. You are very good friends of mine, and we know each other since last 15 years. And Dr.
Madhuri,
Suchitra.
30 years. Madhuri, 30 years.
30 years. Yes, St. George. Yes. And Dr. Suchitra is also my great friend since I will say 30 years. And we have worked together in many occasions. And today also we are together and we are working together for the betterment of the women. So with this, respected Dr. Suchitra Pandit, Chief Guest, and the National President of ISOPA, Guest of Honor Dr. Meena Samant, Secretary National ISOPA, Dr. Lakshmi Srikhande, President ISOPA Vidarbha Chapter, Chairperson Dr. Milind Shah, Dr. Gangadharan Shahu, Dr. Sneha, Dr. Chinmay, Dr. Charmila, Dr. Pragna, Dr. Ashok Kumar, Dr. Rashmi, Dr. Mitra Saxena, my seniors and juniors. Very good afternoon or very good evening to all of you. At the outset, I would like to thank Dr. Lakshmi Srikhande and her team, especially Rashmi Kahar and Lakshmi and her team, their team for inviting me as a guest of honor. We are all aware that pregnancy is a physiological process, but many of our pregnant women can become high risk. Mothers with high risk pregnancy have high maternal and perinatal mortality and morbidity. Hence, they require a specialized care and management to reduce these complications, the disease complication. Dr. Lakshmi Srinkande and her team have selected very important topics, that is diabetes in pregnancy and RH isoimmunization. Today, women are career oriented and have late marriage and late pregnancy. Along with PCOD and obesity, the incidence of diabetes in pregnancy has increased tremendously. Today, at the same time, today we have a good oral hypoglycemic drug as well as injectable insulin. So, if they are properly monitored and properly managed, then we have a very good outcome. The outcomes are rewarding, and I am sure Lakshmi will enlighten us on this, very well. The RH isoimmunization is still most important cause of hemolytic disease of the fetus and newborn worldwide. It can be prevented with proper screening, monitoring, and prophylactic use of anti-D injection. However, some mothers can still get sensitized, and fetus and neonatal may develop hemolytic disease. With advancement in fetal medicine, intrauterine blood transfusion and exchange transfusion in newborn have really reduced grossly the perinatal mortality, neonatal mortality and morbidity. Now the speaker, Dr. Lakshmi Shrikande, moderator Dr. Sneha and the panelists are expert in their field. I'm sure they will guide us to successfully negotiate the challenges we may encounter in management of these high-risk pregnancies. I thank you once again, and I wish all the best for this webinar. Thank you.
Thank you so much, Madhuri. I know you are very busy with the Foxy and Jogi, but you could spare some time and honor my invitation. Thank you so much for being here and giving the brief overview of the topics of today's webinar.
My
Friends,
pleasure,
now,
Lakshmi. My pleasure, Lakshmi.
yes, and if we are a bit free, Madhuri, please wait for
I'm
the.
waiting. I'm waiting. I'm waiting.
Thank you, dear. Now our second guest of honor today is none other than Dr. Meena Samant. She is currently the Secretary General of National ISOPA. सेशन को याद करना पड़ता है, स्लाइड नहीं.
आप एक बार क्लिक कीजिए, इट विल गो अहेड.
मैं एक बार क्या इम्पेशंस होके 4 बार क्लिक कर रही हूँ. Just not moving.
1 second, madam.
हाँ, हुआ. Dr. Meena Samant is senior consultant and head of the department at Kurji Hori Femihe Hospital, Patna, Bihar. She is chairperson Foxy Clinical Research Committee. She is Secretary General of National ISOPAP. She is Vice President of Patna OBGY Society. She was past secretary of Patna OBGY Society. She has delivered the prestigious Kaminira oration way back in 2005. She was organizing secretary for Yuva Foxy and Boxcon, and she is a DNB teacher. She has published many papers in the reputed journals, and she has contributed chapters in many books. She is a very good orator and a great academician and a great friend of mine. Dr. Meena Samant, I invite you to address the audience in the capacity of guest of honor.
Thank you very much, Dr. Lakshmi Srikhande. At the outset, thank you very much to you and your team for inviting me here as the guest of honor. It is indeed a pleasure for me to be here on this platform. I would also like to, congratulate our chief guest and welcome her, Dr. Suchitra Pandit, my president of ISOPAR. Thank you for those kind and very encouraging words for the ISOPAR, madam. And yes, we've had very good heart-wrenching essays from our members, which I assure you, ma'am, you're going to compile into a little booklet so that they are preserved forever. And this we hope to release during the conference on the 4th of October, to which I invite all of you. So, Dr. Madhuri Patel, Madam, a warm welcome to you from ISOPAR. We know how busy you are. Yesterday we heard you and always have been a fan of yours. Your meticulous working, your clarity in your work and your speech. And today sharing this dice with you is also another kind of honor for me. So we have very eminent, chairpersons here today. And the guests, all the speakers and panelists and moderators, they've been introduced by Dr. Madhuri. So I would not like to come between them because I know they have a lot of very good and latest information for us. So with those words, I would like to conclude, and I would request the organizers to take the program ahead. Thank you.
Thank you so much, Dr. Meena Samant, for accepting our invitation to be guest of honor for today's function. Before I proceed, I congratulate Dr. Suchitra Pandit. In your tenure as the president of ISOPAB, it has really grown by leaps and bounds. And you have started so many chapters. You have made ISOPAB very visible. People have now started and coming asking, what is this ISOPAB? We want to become member. So the credit goes to you. And thank you so much. It was a wonderful tenure, Suchitra, as national president. Now I'm moving ahead with the scientific program, and I'm inviting today's chairpersons, Dr. Milind Shah and Dr. Gangadhar Sahu. I would like to introduce both the eminent chairpersons. First and foremost, our dear friend Dr. Milind Shah, who is the patron of Vidarbha ISOPAB. He only motivated Dr. Sneha Bhuyar and we all to start this chapter. And he not only motivated us, he is always constantly looking after us and seeing to it that this chapter flourishes and it goes ahead. Dr. Milind Shah is the past president of National ISOPAB. He was Deputy Secretary General of FAOPS, that is Asia Oceania Federation of Perinatal Societies. He was Vice President FOXY. Joint Treasurer is part, Deputy Secretary General of Indian Society of Aesthetic and Regenerative Gynecologists. He is ex-chairperson of Rural Obstetric Committee FOXY, founder president Infertility and High Risk Foundation. He has been part of in the body of so many organizations. The list is endless. He is a great academician and a great orator. He has contributed regularly to various journals, the research papers. He has authored books. And he is an active Rotarian. Welcome, Dr. Milind Shah. Our next chairperson is Dr. Gangadhar Sahu, a very soft-spoken, humble human being, sir. I mean, it's great that you are here. We always meet on WhatsApp. Nice to see you in person, though virtual. Sir is Dean, INS and Hospital at BBBSR. He is Vice President ISOPAB, and as you can see his biodata, he is such a humble human being that he says that he is forever a student along with a teacher. Thank you so much, sir, for being here. Now I hand over the proceedings to the chairpersons to move ahead. Milind, are you still with me?
Dr. Milind has dropped out, madam.
Dr. Milind has dropped out. Dr. Gangadhar Sahu, can you see the slide? Can you introduce, or I can tell Sneha to introduce me? Sneha?
Dr. Gangadhar, may I request you to kindly unmute yourself?
Or I can introduce.
Yeah, please go ahead. I want to say, yeah, Dr. Meena. Yeah.
Okay, I will take this opportunity while we have missed Dr. Milind to introduce the very dynamic president of Vidarbha chapter, Dr. Lakshmi Shrikande. I think every day she must be on some, she's out on a mission, to teach, and also she's a teacher, I would say. So discussing all kinds of female problems on the forum. So COVID has taught us many things, and this is one of those. So she is Medical Director, Sri Khande Fertility Clinic of Nagpur. She is Chairperson Designate ICOG 2020. And she's the National Corresponding Editor, Journal of Obs and Gynae of India, Jogi. She's the Clinical Secretary, National AMWI, a past Senior Vice President of FOXI, Founder, Patron, and President ISOPAR Vidarbha Chapter. And she has received Nagpur Ratan Award at the hands of Union Minister Shri Nitin Gadkari ji, received Bharat Ratna Excellence Award for Women's Health, received Mehru Adara Hansotia Best Committee Award for her work as Chairperson of HIV/AIDS Committee, FOXI. She has received appreciation letter from Maharashtra government for her work in the field of Save the Girl Child. She is the immediate past president of Menopause Society Nagpur, past president Nagpur OB and Gynae Society. She has visited, almost 96 FOXI Society as invited faculty, delivered 11 orations, 450 guest lectures, many publications to her credit, 11 international ones. She has sensitized 2 lakh adolescent boys and girls on do's and don'ts. Okay, I miss the last line if it is there.
No,
So I present to you a very learned and a very dynamic Dr. Lakshmi Srikhande.
Thank you so much, Dr. Meena, for your kind words of introduction. I must say that I am trying my level best to popularize the Vidarbha chapter of ISOPOP so that more and more members I can encourage many more members to join in. That is my mission and motto when I am having this chair of President Vidarbha ISOPOP. And I assure you I am doing my level best for this association. Friends, today my topic of deliberation is diabetes in pregnancy. Diabetes in pregnancy can be a pre-existing diabetes or it can be gestational diabetes. Pre-existing diabetes can be type 1 or type 2 and gestational diabetes can also be pre-existing diabetes or it can be a true GDM. The pre-existing diabetes is diagnosed before the start of pregnancy. Pardon?
Slides are not seen.
My slides are not visible? Now?
Yes. No. Slides are not visible.
Lakshmi,
I will stop
you
here
need to
and
open your PPT first.
No, it's open. No, there is some net issue
I
there.
think the network issue is there.
Yeah, I think
It's
so.
buffering. It's buffering.
It's buffering. I will just shift to hotspot because it's raining here suddenly. Rains have started in Nagpur. Torturing. Are my slides visible now?
They are coming on, madam. They are coming on.
Now? Are they visible? Chamila?
No, ma'am.
No, no.
No, just give me 2 minutes. Just 2 minutes. Let me shift to the hotspot. Just 1 second. Now I have connected my hotspot. I hope the slides are visible. Just give me 30 seconds. Chamila?
Madam, it's loading right now. So,
Yeah.
I'll inform you when the slides are visible.
Yeah, just tell me now. I have shifted to the hotspot.
No, madam. Madam, may I request you to switch off your video and then try sharing? That would be helpful.
I think that
Okay,
will do.
okay, okay. Permission to remote control my desktop. No, I will. Yeah, I will. Just a second.
Yes, madam. Now you try screen sharing. I think it should
Okay,
work.
now I am trying. Yeah.
Yeah,
Yes, madam. We can see it.
yeah,
I
yeah.
request you to kindly go through the. Yes, madam. Thank you.
I just want to minimize all the videos. Just a minute. Yeah. Now the slides are visible, Shamila?
Madam, they are visible.
Yeah, you,
Yes, ma'am.
one is visible, you advance it.
Yeah, I'm trying to go forward. Yeah. Now can you
Yeah,
all
now we
see?
can see. Yes,
Yeah.
yes.
So my topic for deliberation today is diabetes in pregnancy. Diabetes in pregnancy can be pre-existing diabetes or gestational diabetes. Pre-existing diabetes can be type 1 or type 2. Gestational diabetes can be pre-existing one or it can be a true GDM. Pre-existing diabetes is diagnosed before the start of pregnancy. It is hyperglycemia diagnosed for the first time in pregnancy and it meets WHO criteria for diabetes mellitus in the non-pregnant state. This pre-existing diabetes may occur at any time during pregnancy, including the first trimester. The gestational diabetes mellitus is hyperglycemia during pregnancy, that is not diabetes. Hyperglycemia diagnosed for the first time during pregnancy and it may occur during any time in the pregnancy but preferably in the third trimester. The prevalence is 22 million women between 20 to 39 years. They have diabetes in India. This is 2010 data and this was expected to rise by 20% in the next 10 years and we are in 2020. So it has already risen by 10%. 54 million women with impaired glucose tolerance or prediabetes have the potential to develop GDM if they become pregnant. The prevalence of GDM in India varies from 3.8 to 21% in different parts of the country, depending on the geographical locations and diagnostic criteria used, and it has been found to be more prevalent in urban areas than in rural areas. So friends, I will be covering the definition, screening, diagnosis, antenatal, intranatal and postnatal management and prevention of GDM. Pathophysiology, we all know that maternal hepatic glucose production increases by 15 to 30% to meet the fetal demand late in pregnancy and if this is associated with pancreatic beta cell dysfunction or insulin resistance due to placental secretion, it leads to the development of gestational diabetes mellitus. What is the difference between screening and diagnostic testing? The purpose of screening is to identify asymptomatic individuals with a high probability of having or developing a specific disease. Hence, for gestational diabetes mellitus, we do screening. Whom to screen? The universal screening appears to be the optimum approach as the Indian women have 11-fold increased risk of developing glucose intolerance during pregnancy compared to Caucasian women. Which screening method to use? In India, we all are using diabetes in pregnancy study group of India, that is DIPSI criteria. This is a one-step approach and this has been endorsed by the government of India on 14th March 2007 and India recommends that all women should be screened between 24 and 28 weeks of gestation with this single step method. How to do this screening test? the woman has to take 75 gram glucose with 300 ml water irrespective of the last meal. She has to ingest whole 300 ml water with glucose in 5 to 10 minutes, and the blood sugar is measured after 2 hours. If she vomits within 30 minutes of the intake, you have to call her next day and do the repeat test. Once you have done the test, how to interpret this DIPSI test? If after 2 hours it is more than 200, this is labeled as diabetes. If values are between 140 to 199, it is gestational diabetes. If it is between 120 to 120 to 139, it is impaired glucose tolerance, and if it is less than 120, it is normal. But if it is 200, then you have to look for other comorbidities, look for hypertension, do fundus examination, and look for nephropathy. What are the advantage of DIPSI criteria? Why we are not doing the OGTT which other world is doing it? Because this is a simple, feasible, convenient, economical and acceptable in Indian scenario. In India, our women have to travel long distances for checkup. Hence, this non-fasting single test has become more acceptable to our Indian pregnant women. Moreover, our population is diverse and variable. Hence, international criteria need not necessarily apply to our Indian women. So, in a nutshell, this is how we should go about the screening. If a pregnant woman comes to your OPD, she should be tested for GDM at first antenatal visit with DIPSI criteria. If it is positive, that is more than 140, you have to manage her as GDM. If it is negative, that is values are less than 140, you have to do the repeat testing at 24 to 28 weeks. And if she is positive, manage her as GDM. If it is negative, manage her as normal ANC. The government of India has recommended the universal screening, then the screening at first antenatal visit, then at 24 to 28 weeks, and DIPSI has recommended that this should be repeated at 32 to 34 weeks. Now, why we are giving so much importance to GDM? What is the need to diagnose and treat these condition? Because if we identify these women with GDM, with appropriate therapy, we can decrease the maternal and fetal morbidity. The list I am sharing in my next slide, what morbidities can be there. And not only this, it can prevent 2 generations from developing diabetes in future. The maternal problems which can encounter if we don't control these GDM cases are early pregnancy, there can be spontaneous miscarriages. These women are more prone for PIH, gestational hypertension, UTI, macrosomia, hydramnios. During delivery, they have many more problems. They may land up with instrumental delivery, traumatic delivery, cesarean section, postpartum infections, postpartum hemorrhage, maternal morbidity and mortality. Puerperium, they are more prone for infections and lactation failure, and long-term postpartum, pardon, there is any problem? They can have weight retention and GDM in subsequent pregnancy, and they are at a risk of developing diabetes mellitus and CVD in their later life. Fetal problems, there can be stillbirths, neonatal deaths, congenital malformation, shoulder dystocia, respiratory distress syndrome, cardiomyopathy, hypoglycemia, hyperbilirubinemia, and hypocalcemia. So you can see that just by doing a screening test, you can really prevent so many maternal and fetal problems in the pregnancy. You have diagnosed GDM. What next? Now, how you will manage these cases? The primary management strategy for GDM is dietary changes and exercises. And if it is not controlled with that, insulin is first line of therapy and followed by oral antihypoglycemic agents. In the management issues, you have to educate your patients. You have to provide medical nutrition therapy, though it is ideal to have a nutritionist. Pharmacological therapy, what should be the glycemic control, how you will do fetal monitoring, planning of delivery and postpartum care. This is what I am going to discuss with you in my next couple of slides. During pregnancy, they should receive nutrition counseling by registered dietitian, but most of us, we don't have. You have to advise them to eat healthy and replace high glycemic index foods with low glycemic index foods. and discuss appropriate weight gain and healthy lifestyle interventions throughout pregnancy. The goal of providing medical nutrition therapy in these cases is to maintain adequate nutrition, have adequate weight gain, prevent ketosis, and prevention of postprandial hyperglycemia. This is the diet plan based on the level of activity and BMI. If she is sedentary, then she should be advised the total calorie intake of 2250, moderate work 2580, and heavy work it is 3200. But of course, this has lot many variations and it has to be individualized. Just one slide on diet, that it has to be 30 kilocalorie per kg for normal weight woman, 24 kilocalorie per kg for overweight woman, and 12 kilocalorie per kg for morbidly obese woman. It should contain 50% of carbohydrates, 20% proteins, and 25 to 30% fat. She should be advised to have breakfast, lunch, and dinner, and in between, 2 snacks are permitted to her. Physical activity is an essential component of the medical management of GDM cases. Unless contraindicated, they should be included in her daily regimen. Regular moderate intensity physical activity can help to reduce glucose levels in patients with GDM, but along with it, she needs cardiovascular training with weight bearing limited to the upper body to avoid mechanical stress on the abdominal region. So this is the target weight gain in cases of GDM. If her pre-pregnancy BMI is less than 18.5, means she is underweight, the total weight gain target is between 12.5 to 18 kg. If she is 18.5 to 24.9 BMI, that is she is normal weight, the total weight gain target is 11.5 to 16 kg. If she is overweight, the total weight gain should be 7 to 11.5 kg. And if she is obese, then the total weight gain target should be 5 to 9 kg. About 50% of women who are started with diet alone, they subsequently require additional therapy in the form of insulin. But this insulin therapy must be individualized. But most pregnant women, they require about 0.7 units per kg daily. 2/3 of the insulin is administered in the morning and 1/3 is administered in the evening with a 1:2 ratio of short to intermediate long acting insulin. This is just a general guide, but it has to be individualized. This is again the general guidance on about the insulin dosing weight lines. If she is between 1 to 13 weeks, then she needs about 0.7 multiplied by weight in kg. If she is between 14 to 26 weeks, then it is 0.8 into weight in kg. If she is 27 to 37 weeks, it is 0.9 into weight in kg. And 38 weeks to delivery, it is 1 into weight in kg. For postpartum, it drops down to 0.55 into weight in kg. In certain cases, you have to go with the oral hypoglycemic agents. Metformin and the sulfonylurea glyburide are the two most commonly prescribed oral antihypoglycemic agents during pregnancy. But due to the efficacy and safety concerns, both American Diabetic Association and DIPSI, they do not recommend oral antihypoglycemic agents in the management of diabetes mellitus or pre-existing type 2 diabetes mellitus. But if at all you have to give metformin to these cases, you have to give it with meals. Start with 500 milligram once a day, then gradually increase the dose. The maximum permitted dose is 2000 milligram per day. There is no teratogenic risk which has been demonstrated. It is in the category B, drug category B, and it is still not FDA approved for use in pregnancy. How you will advise your patients to monitor the blood glucose? It should be done at least 4 times per day, that is self-monitoring. She has to do once fasting and 3 after post meal, that is post breakfast, post lunch and post dinner. After achieving the target level, the lab monitoring is advised once in a month till 28 weeks. Every 15 days between 28 to 32 weeks, and if she is more than 32 weeks, once a week, the lab monitoring is definitely advised. And don't forget to monitor her fundus and monitor her for microalbuminuria. The glycemic targets which you have to maintain are mean plasma glucose 105, fasting 90, postprandial 120, and the mean plasma glucose should never go below 86. This is in a nutshell the slide to summarize the management of pregnant women with GDM. First and foremost is medical nutrition therapy, which contains diet and exercise. Give it for 2 weeks. After 2 weeks, if her 2-hour postprandial blood sugar is less than 120, continue MNT and physical exercise. If it is more than 120, you have to start oral antidiabetic. Choice is yours. Based on the patient characteristics, you decide whether you want to start her with metformin or insulin therapy. How you will monitor her during pregnancy, that is now the pregnancy part we are coming. In the first trimester, apart from clinical exams, dating scans, NT scans, you have to do biochemical screening, do the Doppler studies for seeing for the early changes of preeclampsia. Middle cerebral artery Doppler should be done for detection and monitoring of intrauterine growth restriction. In the second trimester, clinical exams, anomaly scan at 19 weeks, triple or quadruple marker, you have to monitor for amniotic fluid index, and fetal echo at 22 weeks is recommended. In the third trimester, apart from clinical examination, you have to be very alert and you have to monitor the fundal height, abdominal girth, do growth scans as and when required, but compulsorily do it at 28 and 32 and 36 weeks along with color Doppler as and when indicated. Monitor her amniotic fluid index and see for any growth restriction or the abnormal weight gain in the baby. Fetal monitoring, the baseline ultrasound should be done at 18 to 22 weeks. Major malformations and fetal echo is advised. 26 weeks onwards, growth and liquor volume, and third trimester onwards, you have to monitor the baby weight and the growth parameters. When to deliver these women? The FIGO recommends that at 38 to 39 weeks, if there is no obstetric indications, they should not be delivered before 38 weeks. So when she has reached 38 to 39 weeks, and if the baby weight is 3.8 kg, see that you have to see if she is a poorly controlled, if she has a poor compliance for your therapies, or if she is any high risk factor. If these are not there, you continue this pregnancy till 40 to 41 weeks. But if the baby weight is 3.8 to 4 kg or this is large for gestational age, there is a poor control, poor compliance with your therapy, you feel that this is a high risk pregnancy, then you can induce labor at 38 to 39 weeks. If at 38 to 39 weeks, if the weight is more than 4 kg, you are justified in offering a cesarean section to this woman. During labor and delivery, you have to monitor for hyperglycemia in pregnancy. CTG is definitely needed. Partograph blood sugar by glucometer every 2 hourly. Your target level should be 80 to 120 and you have to continue fetal monitoring throughout labor. During second and third stage, in the second stage, go ahead with controlled ARM, anticipate shoulder dystocia, be prepared for assisted vaginal delivery, and if there is any problem, you should have a neonatologist or a trained person ready to resuscitate this baby. Do active management of the third stage and watch for the traumatic or atonic PPH in these women. If she is on insulin, then you have to monitor very carefully her during labor and delivery. If she has delivered successfully, then how you will monitor her postpartum care. If she was throughout on medical nutrition therapy, then you can stop her blood glucose monitoring immediately after delivery, give her regular postnatal care, but offer her OGTT 6 weeks postpartum. If she was on oral drugs, then in most women, glucose tolerance, it normalizes immediately after delivery. You can stop pharmacological therapy immediately after delivery. but continue with the blood glucose level monitoring 4 times in a day for first 24 hours. If preprandial blood glucose level is between 72 to 126, you can discontinue monitoring. If blood glucose levels are less than 72 or more than 126, then you have to seek medical review and continue monitoring. 1 to 8% of these women may continue to be glucose intolerant and they need further oral drugs. You can continue the metformin or whatever drug she was initially on. If this woman was on insulin, then after delivery you have to do her blood glucose monitoring, continue 4 times a day for 24 hours. If blood glucose is more than 126, you can do medical review and start her on oral drugs. Insulin therapy is generally not indicated unless there is a marked fasting hypoglycemia once this woman delivers. What are the risk factors for persistent diabetes? If the pregnancy fasting glucose levels are greater than or equal to 126, the diagnosis of GDM was done during the first trimester, or if there was a prior history of GDM without documented normal glucose tolerance outside of pregnancy. How you will monitor for these persistent cases? You have to recommend OGTT at 6 weeks postpartum to screen for persistent diabetes, recommend lifelong screening for diabetes every 3 years, and advise early glucose monitoring in future pregnancy. Can she breastfeed? Yes, they are encouraged to breastfeed immediately after delivery in order to avoid neonatal hypoglycemia. They should continue breastfeeding for at least 3 to 4 months postpartum in order to prevent childhood diabetes, childhood obesity and diabetes in the offspring. And this breastfeeding also reduces the risk of type 2 diabetes and hypertension in the mother. Don't forget to give her contraceptive choices. She can use all the methods of contraception starting from barrier, long-acting reversible contraceptions, the injectable contraceptives, the combined oral contraceptive pills, implants, rings, unless and until they are contraindicated because of the presence of microvascular disease. Can we actually prevent GDM? In women who are at high risk for GDM, based on pre-existing risk factors, nutrition counseling should be provided on healthy eating and prevention of excessive gestational weight gain in early pregnancy, ideally before 15 weeks of gestation, to reduce the risk of GDM. So friends, to summarize my talk, the key points are universal testing should be advised to all pregnant women for GDM. Testing is recommended twice in pregnancy, first during first antenatal visit and then at 24 to 28 weeks of gestation. DIPSI recommends additional screening at 32 to 34 weeks. Single step 75 gram 2 hour OGTT is the best preferred method. Pregnant women who test positive, that is after 2 hours, values are equal to or more than 140, they should be started on MNT for 2 weeks. If 2-hour postprandial blood glucose is more than 120, after starting with this medical and physical exercise, medical management in the form of metformin or insulin is started. Early delivery with administration of prophylactic corticosteroid therapy for fetal lung maturity to be planned only if uncontrolled blood sugar or there is any other obstetric indication where you are planning to deliver her. Please mute yourself before 38 to 39 minute session. सबको mute करो. Vaginal delivery is preferred. Remember, presence of gestational diabetes is not an indication for cesarean section. It should be done for only obstetric indication or if there is fetal macrosomia. Neonatal monitoring for hypoglycemia and other complications should be looked for, and postpartum evaluation of glycemic status by a 75 gram OGTT at 6 weeks after delivery should be done without fail. So this is the way we all treat our women. So we have to start looking to our woman folk right from the adolescent age so that she becomes a healthy mother and she delivers a healthy child. Thank you so much, friends, for your patient listening. Milind, have you joined?
Uh, Thank you very much, Lakshmi. I'm so sorry. Actually, I'm traveling, and this Corona pandemic has changed everything. And after a long interval, I could go to my Mumbai center, and I pardon all my viewers as well for joining little late, and I got disconnected in between. But when I was listening to your presentation, I was so happy, Lakshmi, that you covered all the aspects of GDM and the pregnancy, as well as the postpartum aspects, which is very, very important. I'm really happy to see all this progress of Vidarbha Isopap. As you said very correctly, a small seed which I bought that was long back with the help of Sneha and you has now grown to such a great tree, and I can see all that progress, good activities. I must say big thanks to you for inviting me today for this particular session, and I'm very sure all these actually the facts which you explored as far as the GDM is concerned will be beneficial to all our viewers. Yes, Dr. Gangadhar, you can also give your comments.
Okay. Thank you, Milin. Madam Lakshmi had described GDM in such a beautiful way that I have to give the concluding remark if there is no interaction or question answer session. So just to add that this GDM is the management of GDM is a totally a teamwork. So the team means you, the obstetrician, are the leader. You must have one dietitian. You must have an endocrinologist or physician. In your team, you must have a skilled anesthesiologist who is skilled in obstetric practice, a very good neonatologist, and a midwife. So that comprises your team. Am I audible?
Yes, sir. Yes, sir. You are audible.
So that your burden or the responsibility becomes less and you can have a very nice sleep during night. So next thing is monitoring. Whom to monitor and who to monitor. So mother's education is important because mother is the best monitor for herself and for the fetus. Therefore, unless she is educated, so it is very difficult for you to monitor the mother. So therefore, the health education part is very, very important. That should be concept. Second thing is the monitoring during antenatal period, monitoring during internatal period, and monitoring during the immediate postnatal period. These three parts that should not be neglected even for a second. So because during antenatal period, if everything goes well, so far so good, as per the DIPSI guideline, you have to monitor. And during intrapartum, either on the cesarean section or in labor, so first thing is fluid and electrolyte balance. Which fluid you should choose. Overnight medication should be stopped. Early morning you start a drip, preferably a normal saline. Then monitor the blood sugar. According to it, you can go for short intervals of insulin therapy, maybe added to the drip. So that is the throughout the procedure, maintaining the new glycemic state. At no stage
Hello, Dr. Sahu, sir. I think there is some network. Madhuri, since you are here,
Yeah,
you would
yeah.
like to add something. Madhuri, you want to give some remarks?
Lakshmi, thank you very much. And it was an excellent and very well, presented your diabetes in pregnancy topic. And really, we how to work on this. We can prevent by only screening. You can prevent almost so many, neonatal and the maternal and the fetal complication. So we should make aware all our obstetrician that it is a must. Previously, in the past, it was not a must to screen the patient for diabetes, gestational diabetes, but now it is universally accepted. And so, hence, people who are there not in an academic, we should give them the message that this is the condition you how to treat, and you can prevent so many complications, maternal and fetal and neonatal. That's all.
Yes, thank you, Madhuri. Now, sir, you have
Thank you,
logged in.
Lakshmi.
Sir,
I
you
think
want
there
to
are two
continue? Yes,
questions coming up from the audience. Lakshmi,
Milind, we will
there are
take
two
after
questions.
Sneha's. Milind, we will first finish with the
Okay,
Sneha. Please
okay,
stop
okay.
your screen sharing. I would like to introduce you
Yes,
first.
after the
Sneha.
panel, we'll take the questions.
Yeah, after panel. No, I just wanted Dr. Gangadhar Sahu. Are you
Yes,
here
yes.
with me? No, he. Dr. Gangadhar Sahu. Sir, you want to say something? You were in the middle of your talk. Your network got some problem. You wish to continue, sir? Gangadhar sir? Should I continue with the panel then?
Yes, yes. I think we'll go for
Yeah.
the panel, then we'll take
So
the questions
now
after that.
I see lot many questions in the chat box, friends. We will be answering each and every question. But let us first move on to the panel discussion, which is case-based panel discussion on RH isoimmunization. This is moderated by none other than Dr. Sneha Bhuyar, a great academician. She is the person who gave birth to our Vidarbha Isopap chapter, and not only gave birth, but she is really nurturing this chapter, and she has a lion share in having Vidarbha Isopap to this present status. Thank you, Sneha, for being always there for Vidarbha Isopam. Friends, Sneha is currently chairperson, study on female breast disease committee, FOXY. She is governing council member of ICOG. Recently, she has won this election. She is recipient of, why this screen got session. Are you sharing? Ah, she is recipient of National Award for FOXY. She is the recipient of a very prestigious Anandibai Joshi Award. She has also in her kitty the Lokmat Excellence Healthcare Award, and I see the list is endless, Sneha. So excuse me if I am not reading the whole list of awards. She was president of Yatmal Obstetric Gynec Society. She was, as I already said, she is the founder president of our Vidarbha ISOPAC. She has organized many conferences, and what I appreciate most is that she is organizing such big events, national events at a very small place, that is Yavatmal, and you are instrumental in bringing Yavatmal to a national map, Sneha. The full credit goes to you. She is a great orator. She has delivered many orations, guest lectures, and she has contributed many chapters in the textbooks as well. So, Sneha, you will be moderating, and I will be introducing the panelist as well. Session, now you are sharing. The first panelist is Dr. Chinmay, a very smiling, always helping Chinmay. Welcome. She is a fetal medicine consultant, and she will be providing a lot many inputs as a fetal medicine specialist to this panel, because the concepts have really changed, and the way they manage these cases are different from how we manage as a gynecologist. She is running a ICOG FOXY recognized certification course in her Center for Fetal Medicine. She has 15 research papers to her credit. She is chairperson of Fetal Medicine Committee, and recently she has won the elections, and now she will be the chairperson of Perinatology Committee of FOXY, and she is a great academician. Welcome, Chinmay. Next slide. Chamila. What to say about Chamila? She is always there, a very charming person, a great academician. You just phone her at any time, Chamila, we need this, we need this. And Chamila is always there. She is always say, yes, madam, I am sending. Chamila, thank you so much for being always there for me. She is chairperson. She was chairperson of Clinical Research Committee, FOXY. She was president of Menstrual Hygiene Management Consortium. She is director of Aditi Hospital and Parvati IOP Fertility Center, Trichy. She is consultant to Southern Railway Hospital, Trichy. She has been awarded with many awards. She was organizing secretary of UFOXY South Zone, and she has won, my God, 5 trophies of FOXY as secretary, Trichy OBGY Society. Congratulations, Chamila. She is recipient of prestigious Mrs. and Mr. N.A. Pandit Prize for Women Empowerment. She has been also awarded with Dr. Merudara Hansotia Prize for the Best Committee Work in 2018. She is ICOG Governing Council member, and I am looking forward to work with you. I mean, Chamila, you will have to really contribute very substantially. I am having great expectations from you as ICOG Governing Council member. Welcome, Chamila, for this panel. Next slide. Pragya, a dear friend, in spite of so many adversities, she always is having a positive outlook towards life, always keeps on smiling, a very humble human being. Currently, she is the treasurer of National ISOPAP. She is consultant infertility specialist and colposcopy specialist with special interest in fetal medicine. She is secretary Patna OBGY Society, chairperson genetic and fetal medicine. Pardon? She was founder secretary of Bihar chapter of ISAR. She is running FOXY certified colposcopy training center. She has awarded with many awards. She is invited faculty to so many conferences. She was organizing secretary for FOXY Spark conference and also for 24th Boxon in 2014. Welcome Pragya for this panel. Next slide. Dr. Ashok Kumar, a silent worker. He works from behind the curtain. I welcome you, Dr. Ashok Kumar. Recently, he has been elected as the secretary for ICOG and he is currently governing council member. He is working in he's professor in Department of OBGY at Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ram Manohar Lohia Hospital, New Delhi. He is in the editorial board member of our Indian Journal of Medical Research and Archives of Gynecology and Obstetrics. Dr. Ashok Kumar, I welcome you for this panel. Next slide, please. Dr. Mitra Saxena, my dear friend, charming, smiling, beautiful lady, also with lot of positivity around her. She is director at Sri Ashwini Saxena Hospital. She also comes from a very small place, Rewadi, and she has brought Rewadi to the national map, Dr. Mitra. Really, this is commendable. Recently, she has won the elections and now she will be representing Rewadi to the FOXY. She has contributed to FOXY a lot. She is past president of Rewadi Obstetrics and Gynecological Society, contributed many chapters in the textbooks. She was project director for many projects. She was North Zone coordinator for FOXY Breast Committee. She is a national faculty, regularly invited as an orator and as a guest lecturer for so many places all over India. Welcome you, Dr. Mitra, for this panel.
Thank you.
Rashmi Kahar, my very own sweet, young, dynamic lady from a place called Amravati, which is near Nagpur. Rashmi is always smiling and helping. Thank you, Rashmi, for coming to this panel. She is consultant OBGYN at Amravati and currently she is joint secretary with her ISOPA. I look forward for you to currently actively contribute in this panel, Rashmi. Have we finished all the panelists? Now you stop. Floor is yours, Sneha. Please go ahead with your panel on RH ISO immunization.
Yes, thank you so much, Lakshmi. Thank you so much, Lakshmi. At the outset, I would like to welcome all of you for this academic session. I would like to thank my mentors, Dr. Suchitra Pandit, Dr. Milind Shah, Dr. Lakshmi, Dr. Madhuri Patel, and all my dear friends. All the viewers, I would like to welcome you for this session. I welcome Dr. Ashok Kumar, Dr. Charmila, Dr. Pragya Mishra, Dr. Chinmay, Dr. Mitra Saxena, and Dr. Rashmi. Welcome to this panel. As you know, we are going to discuss RH ISO immunization today. And just make this slide show. Yes. So, Friends, you know why I'm very happy that Lakshmi you have selected this topic, because as you all know, though this is a quite a rare condition nowadays, not many patients you get of RH isoimmunization, but whenever you get the cases, they are severely affected and the perinatal outcome is definitely very bad. And that is how you can definitely, but you when you have the high index of suspicion, you can prevent it, you can predict it and act accordingly, and you can keep a high index of suspicion so that you can timely manage these cases. So when we talk about RH isoimmunization, as you all know, that the fetal blood formation starts by third week, and the D antigen, that is the RH antigen, is identified on the fetal RBC by 38th day of conception. The fetal RBCs, they have more than 40 antigens. They are grouped as RH, Kale, Duffy, Teed, MNS, Lewis, Lutheran, and so many, more than 40. And according to Fisher and Rich theory, the RH antigen is inherited as a complex of three loci: capital C, small c, G capital, and E capital and small. In a RH negative woman, suppose the RH negative woman marries a RH negative man and they conceive a fetus who is RH positive. These are fetal RBCs which are RH positive. They travel or enter into maternal circulation and they produce the immune response, which is quite slow. It takes 6 weeks to 6 months almost to develop the antibodies, and they are IgM antibodies, and they do not cross the placental barrier. But when there is re-exposure, maybe in the next pregnancy or same pregnancy in the later part of the pregnancy, whenever there is fetal-maternal hemorrhage, now the response is quick. Within few days, she develops the antibodies, which are IgG type of antibodies. They cross the placental barrier, enter into the fetal circulation, get attached to the D antigen on the fetal, and then they are sequestered in the spleen. They are hemolyzed. So this hemolysis leads to increase in the level of amniotic fluid bilirubin. Now, because this initially there is less hemolysis, we have the only rise in the amniotic fluid bilirubin. But when this becomes severe, then of course there is severe fetal anemia and production of RBCs in the liver and spleen, leading to hepatosplenomegaly, and then the obstruction of the hepatic circulation, leading to the hypoproteinemia as well as generalized edema, that is anasarca, the placental edema leading to placental function impairment, and a very fatal outcome, maybe intrauterine fetal death, or maybe the high drops and severe neonatal hyperbilirubinemia. So once we predict this, we can definitely have high index of suspicion. We can intervene timely. So that is how we want to take up this discussion. And now I just go to the first panelist, Dr. Rashmi. I'm giving you a very simple day-to-day case. Please note, we have a primary gravida who is only 3 months of pregnancy at present. And now she just recently came to know that she is RH positive. Now, listening to the story, she started worrying about her pregnancy outcome. How do you counsel and how do you manage her? Rashmi.
Thank you, madam. Thank you for this case. Mrs. XYZ, who has come to OPD, is very well aware of the fact that she is RH negative and she is worried about it. But here, we don't know the blood group of her husband. So the first thing I would like to know what is the blood group of the husband. So let's, for the purpose of discussion, assume that the husband's blood group is positive. And then we have to counsel the patient regarding the consequence of if there will be isoimmunization or not. Because this is the first pregnancy, the chances of isoimmunization are very less in this pregnancy.
You want to do, Rashmi? I interrupt you here. Anything before you want to do the husband's blood group? Do you want to do any investigation?
Yeah, I would like to do, if the patient is affording, I would like to know if the zygosity of the husband, if he is heterozygous or homozygous.
Before
So,
that,
for example,
we are not even doing husband's
ICT.
blood group. Before that, she is RH negative.
indirect Coombs
Whether
test,
you want to confirm that she is really RH negative.
yeah, we would like to confirm whether she is really RH negative. So, we would
What is
repeat the test.
what is RH null? What is DU?
Uh, we would like to repeat the blood group and get it confirmed, because many a times it happens that the report may vary from, in rare cases it can vary, so we can just get it repeated.
Yes, sometimes it can happen that even it may be wrongly labeled as RH negative. Sometimes it happens that the patient is having an antigen what is called as DU, that is RH null. Okay, so sometimes what happens, because of the C allele, this D antigen is expressed weakly. So the report comes as negative when she is actually RH positive. That is also one possibility, and that is the reason we are supposed to confirm that she is RH negative. Okay, go ahead.
Yes, because this is the first pregnancy, we can really counsel her and assure her that there is no much need to worry about the isoimmunization. But still, we would like to get ICT done, give her antenatal prophylaxis doses of anti-D, and counsel her that when she will be delivering, she has to take an injection anti-D within 72 hours of delivery to prevent further isoimmunization and to prevent further affection of children.
What precautions you would like to take at delivery?
Madam, initially we used to say that late clamping, etc., but now that is not valid. Cord, the length of the cord can be kept really long, so that we can get the blood group of the fetus done. Moreover, get the direct Coombs test of the fetus. Do not give fundal pressure. Do not carefully manage the third stage of the labor. Do not pull the cord. Let the placenta get expelled on its own. These are some of the precautions we can get. Moreover, we can really avoid the contact of fetal blood and perineal injuries, or say, for example, episiotomies of the patient, so that we can avoid further isoimmunization.
Okay. Anyone wants to add anything to this?
Whenever RH negative mother comes, please accurately estimate the gestational age, because the treatment will change if you're going to have different ages as you go on. So please estimate it correctly when you're doing checking at the first antenatal visit.
Yes, so that was the role for the baseline scanning. Okay, Rashmi. So now we go to the next case, Dr. Mitra. Mitra has requested for this case. So,
It's okay.
please, you have this Mrs. ABC, second gravida, who has had a first spontaneous abortion, and now she has 4 months of pregnancy. She is confirmed RH negative. Her first spontaneous abortion was at village, and she has not received anti-D that time. Now she is worried about her pregnancy outcome. Again, how do you investigate, manage, and counsel her?
So, thank you. Actually, thank you, Dr. Lakshmi and Dr. Suchitra Pandit, Dr. Sneha, all of you, because it's a great learning experience to hear good talks and also participate in an active panel like this one. So, okay, thank you, Dr. Sneha. This is a patient who's RH negative and she did not receive anti-D. In fact, the first thing that I would like again is to know the blood group of the husband. So if the blood group of the husband is negative, then we can safely reassure her that her story of RH just ends there. But if the husband is positive, then what we will like to know is, because we expect that if there is any fetal-maternal hemorrhage due to previous pregnancy, patient should have received anti-D. Now, in this case, if she has not received anti-D, what we'd like to do is, after confirming the blood group of the husband, we would like to do a ICT so that we know that any damage was done in the last pregnancy or not. So we take it from there. if the ICT is negative, once again, we can tell her that she has been saved from any ISO immunization. However, we have to educate her about the possibility of getting immunized in this pregnancy. So the rest of the management will be the same like the last case. And we have to follow, if the ICT comes positive, then the game changes. If the ICT remains negative, then we have to do all the precautions of managing this pregnancy, being alert, taking all the precautions which have been enumerated, and giving antenatal anti-D. But if ICT becomes positive, then then there is no role of any giving prophylactic doses of anti-D, because then the management is totally based on the how the titers increase.
Yes.
One thing important
so now
is that if a patient has ICT, hello,
yeah,
hello,
say.
So the bottom line is the same, that in this patient we have to establish at the very outset whether she has suffered any problem because of not receiving anti-D. That is the $1 million question. And if that is answered accurately, then the management goes according to what is the result of ICT.
Yes. So we'll come to it on the next case. Dr. Mitra, see, we have already said that the incidence of RH sensitization is less. So it doesn't mean that every RH negative mother who has a RH positive husband will land up into sensitization. So what are the factors? How do you counsel her, in other words? What are the factors? Yeah, please go ahead.
Actually, one thing is there, that if there is ABO incompatibility, that is kind of, if the mother is O positive and the husband is AB positive, what will happen is, because of the innate immunity, if any A positive or B positive cells come into the mother's circulation, they will be destroyed before antibodies can be brought up. So that is one protective thing we always must remember in decreasing isoimmunization for RH. However, everything depends on the level of fetal-maternal hemorrhage that could have happened. Either if she is aborted at 4 months, if she had been bleeding, if she was a case of bleeding for some time before she aborted, then the chances of fetal-maternal hemorrhage is there. So if we would have assessed the amount of fetal cells in the maternal circulation and given her anti-D, then that isoimmunization would have been protected.
Yes.
And of course, the responder, the woman herself, how she responds with the antibody formation.
Yes,
so many factors.
As like any other immunological response, the inborn inability of that particular individual to respond to the antigenic stimulus, which is RH.
And also the volume of fetal-maternal hemorrhage.
Responders who are always there. So these are the two factors main, in addition to the strength of the RH antigen stimulus and the fetal-maternal hemorrhage, as you rightly said. So these are all the factors, in addition to, it is not just because she's RH negative and her husband is RH positive.
Many times in practice, we find that women have had 1 or 2 deliveries in the village and they're RH negative and they still are not isoimmunized. So that is exactly why nature has taken care.
Yes, so that is how you are supposed to explain it to the patient. So how much fetal-maternal hemorrhage do you expect for getting sensitized? And in addition to fetal-maternal hemorrhage, do you get really the spontaneous isoimmunization as well? So please throw some light on this.
Spontaneous fetal-maternal hemorrhages does take place throughout the pregnancy. However, it is the amount of fetal cells which spill over into the maternal. Am I supposed to answer it or?
Yes, please.
Okay. So the maximum spontaneous fetal-maternal hemorrhages occurs in the 3rd trimester and at the time of delivery, which is up to 30%, and it is much lesser in the 1st trimester and the middle trimester. And for the volume of blood amount needed for sensitization, if we have more than 5 ml of fetal-maternal hemorrhage, then 65% the isoimmunization will be there. Basically, not as you said already, if the immune response of the mother is good, then there will be more antibody formation.
Yes, very well said, Dr. Mitra. Now we go ahead with the third case, Dr. Pragya Mishra. We have the second gravida with para 1 who has delivered a normal baby, female child, vaginally, full-term pregnancy at village, and that time she has not received anti-D. Now she comes to you with 6 months pregnancy, and when you investigate her husband is RH positive, confirmed. Her ICT is positive. How do we manage her? Dr. Pragya, please.
Yeah. Actually, before I go to the actual case, I just wanted to mention that, paternal zygosity is something which,
Yes.
ideally, which we should be
Exactly.
doing. But
Exactly.
somehow, in our scenario, it doesn't happen. Because if, the father is, homozygous, then of course, and then the baby will be RH positive, 100%. But if the father is heterozygous, then there's a 50% chance of the baby being RH positive. So that, it helps us, in deciding, later on that who are the women to whom, you really need to give anti-D, or the ones, who need to be investigated for fetal anemia. So so paternal zygosity and fetal genotyping. I just mentioned it, but somehow, most of us are not doing all that. So basically now this patient, if you could just flash the third case. If you could just flash my last. Yeah. So now this patient, now that we know that she's already ICT positive, so next step would actually be to look for the titers, the anti-D titers in her blood. Now, different, laboratories they have different critical cutoff levels, but it's usually between 1:8 to 1:32. Now, it depends, which laboratory we are sending it to. So,
Yes.
but roughly, suppose if the titer is about, 1:32, it means that, the baby is at risk of developing a fetal anemia. And the next step would actually be doing an ultrasound and also doing, specifically, you go for middle cerebral artery peak systolic velocity. So you look for that. Now, again, now we have these Mary's charts, and according to that, on middle cerebral artery peak systolic velocity, if it's greater than 1.5 multiples of the median,
Yes.
then it means,
I would like to interrupt you here. We are going to it later on, but just to confirm, as you were talking about zygosity,
yeah,
after amniocentesis, can we know this? From the fetal cells,
yeah,
see, we have already, the husband is RH positive and the husband if is heterozygous. So once you do the amniocentesis, can we know the fetal genotype as well? And then
yeah, we can.
revise.
It's just that, those things are slightly obsolete now, just doing the fetal genotyping from amniocentesis. The newer thing is, that you go for cell-free fetal DNA.
Yes.
Cell-free fetal DNA testing from the mother.
Yes, yes.
That's what, nobody does, amniocentesis for fetal genotyping these days. So, yeah.
Correct. So we have so many investigations here, including the chorion villus sampling if she had come early, amniocentesis, cordocentesis, and the most non-invasive and the recent one, easily available nowadays, the cell-free DNA. So definitely this is going to change your management. If the fetus is RH negative, even if it is ICT is positive, your management is going to change.
Yeah, because if the fetus is negative, then we needn't worry. Then two things, as I just mentioned, that one is that, we don't need to give a prophylactic anti-D. One is that. And even prior to that, you don't have to do the surveillance for anemia, fetal anemia. So those are the advantages. So if you can do cell-free fetal DNA testing for this, it's very good. But, hardly, many of us are doing because, it's expensive also. So that's one of the reasons. So, if I could go back, so if the, if the middle cerebral artery peak systolic velocity is greater than 1.5 multiples of median, that means, that the baby is probably developing moderate to severe anemia, and then you would have to go for, a fetal blood sampling and even fetal blood transfusion. So, now, do you want me to tell you of the steps of?
No, we go to the next. See,
Okay.
We have just come up to this. So, amniocentesis. What all things you would like to do, Dr. Pragya? Please let us know what all things we want to do from amniocentesis.
Okay. Now, that's what actually, actually in earlier days, that's why I'm not. Earlier days they were going for amniocentesis. They were doing, bilirubin spectrophotometry analysis and doing OD450 and all that. Looking for and plotting it on Lily's chart, depending on whether she's in zone 1, 2, 3, and that would decide whether she has mild, moderate, or severe anemia. But again, the newer management is not, doing that. One would actually go for, again, stressing on middle cerebral artery peak systolic flow velocity because it's non-invasive.
Yes.
So you would go do that. Yeah. Yeah. One more thing, but just to say that, well, sometimes, if you are going for an amniocentesis, then, I mean, earlier days when, people were also, I think that would be irrelevant really mentioning, stretching that bilirubin spectrophotometry. But basically the whole idea, it was like about several decades ago, that was the method of managing RH immunized pregnancies.
Yes, that is the exactly message we want to give even while investigation, as far as possible, the non-invasive ways, right from cell-free DNA and of course the middle cerebral artery peak systolic velocity, which is so predictive and so diagnostic. Okay, so thank you so much.
So for actually every step of RH isoimmunization, if you see there is one older management and there is a new way of managing. Starting from the very beginning, things have like really changed in the last, 1 to 1.5 decades.
Okay.
May I add one thing, Dr. Sneha?
Yeah, please.
Sometimes, like the good clinical cases that you presented, sometimes a woman who has not received anti-D in the last pregnancy turns up with positive ICT, but while we are monitoring, the ICT does not increase. It just stays stationary. So we have to keep in mind that maybe this time the baby itself is RH negative, so that there is no rise, and we do not let our guard down. We do keep monitoring, because in our scenarios we don't have facility to do RH testing for the blood of the baby, chordosynthesis normally. So we continue the monitoring, but we keep this possibility that this isoimmunization was from the last pregnancy, and no rising titers does give us a clue that it could be that this time the baby is RH negative.
Yes. So coming to the next case, Dr. Charmila, this is a case for you. Third gravida, first spontaneous abortion, second delivery, but this time it was a 6 months preterm delivery because of intrauterine fetal death. And now this time she has come to you with 3 months pregnancy. How do we investigate and manage this patient?
As you said, for the first case, I will repeat RH for the mother, for the father, confirm all that. And then I will do an ICT titer because I need to know whether she's immunized. If she is immunized, there's no critical value for her because she has suffered a perinatal loss already. So the management will go ahead with her middle cerebral artery peak systolic velocity, and that I need to wait till 16 to 18 weeks to start that. So at 3rd month, I will just date her pregnancy, make sure that the dates are correct, check all this, do a critical value, and then start the PSV value from 16 to 18 weeks. And it will be done according to the mom values which I get. If the mom values are nearing 1.5, the monitoring will be at least twice a week. And suppose it's lesser than that, 1 to 1.25, that's what my fetal medicine specialist does. Then we do it once in a week. And when it reaches that 1.5 moms, we'll go on to the intrauterine transfusions. And usually she will take over by that time. And the transfusions will be continued once in 2 weeks until she attains 35 weeks of gestation. And then the fetal surveillance also will start at 32 weeks, the other parameters also. And then at 35 weeks, we'll take a call on her and probably deliver her around 37 to 38 weeks. And she will be managed in a tertiary care where every facility is available for her.
True, very true, very well said, Charmila. In fact, because this is a patient who is having previously affected pregnancy already. So we have that she is already sensitized and she has already suffered. So directly at 18 weeks, we do her titers and monitor her intensively. As you had said very rightly, middle cerebral artery peak systolic velocity every 1 to 2 weeks till the fetus is mature. So I think very precisely and very well mentioned, Charmila here. Anyone to add anything? Any
No,
panelist wants to add
complete.
anything? So
Very nice.
now, yeah, very precisely answered. So definitely, I think our discussion is going on in a very right track, as we have already said that we should only messages to be given here, even though the incidence is very low, quite low, rather it is decreasing day by day. We have to have high index of suspicion, and of course we should have the definitive strategy for management so that we can detect at the earliest and we can prevent the complications. I think Dr. I
Chinmay.
think Dr. Chinmay, yeah.
Yes.
Actually, I'm so happy that Chinmay didn't come with my case because I know she would have taken over the entire patient.
No,
At
no.
least for the delivery part, you should send her to me, Chinmay.
Yeah. Please, Dr. Chinmay, I would like to have you this case.
She's a third gravida with 2 abortions and 26 weeks. Husband is rhesus positive, ICT positive at 1 in 32, and the amniocentesis OD 415 zone 2 hematocrit 30%. How and when? Now, madam, like Pragya madam also mentioned, this amniocentesis OD is currently, even labs are not doing it, and we have given this up as of now because the MCA peak systolic velocity is a very, very good method of monitoring a fetus in utero. What we need to understand in Rh negative is, like everybody else has mentioned, we are only trying to prevent fetal anemia, because once those antibodies reach the fetal circulation, and if that fetus is rhesus positive, these are positive antibodies there, and therefore they will destroy the positive blood cells. So if the fetus is rhesus positive, it has a risk of anemia. All we are looking for in a isoimmunized woman is whether the fetus is anemic or not. If the fetus is anemic, it needs to be given blood, and that blood can be given by intrauterine transfusion. So when you see an ICT positive at a titer of 1 in 32, that means even at 32 dilution, it is positive, it is significant. Husband is rhesus positive, so most likely she has got isoimmunized in her previous pregnancy. You may once repeat after 2 weeks to see whether they are rising titers, because like Mitra ma'am also said, it just makes a little more things into perspective. But really after that, it all depends on MCA peak systolic velocity. This is a 26 weeks gestation. If we do an MCA Doppler, the peak systolic velocity is expected to be less than twice of that gestation age in weeks. For example, at 26, if it is more than 52 centimeters per second, I would suspect fetal anemia. So when you plot into graphs, you will get in multiples of median. 1.5 MOM corresponds to twice the value in weeks. So for 26 weeks, 52 is the maximum. For 28 weeks, 56 is maximum. So that way you can have a ballpark figure. If there is risk of, if there is a sign of fetal anemia, then we will plan transfusion. Now this fetal hematocrit nowadays is done as a one-shot thing. You put the needle in, you take the sample for the first time, take out the fetal hematocrit from the first sample, start transfusion. In the meantime, your assistant calculates that hematocrit and what is the deficit and tells you what volume you have to transfuse, and then you do the transfusion. Once you have done the transfusion, then the follow-up is every week, like we have already discussed. Suppose she...
I would like to interrupt you. How do you calculate the transfusion protocol?
Ma'am, the hematocrit of what is expected, what do we want, and what exactly is there. So the blood that we give for fetal transfusion is a different blood. It is not the routine blood that we give to the other patients. It is O negative, gamma irradiated, leukodepleted, and with a very high hematocrit. Most labs are able to give us some 90, 92 hematocrit. So a very small volume of that is transfused, and there is a formula. The person who has explained this entire thing has given a formula of how much we have to transfuse. So when we put it in that formula, which includes the deficit, what is the current hematocrit, what is our target hematocrit. Target hematocrit we keep about 45, 50, sometimes about 60 also. So if that deficit, we can calculate the volume that is required. Usually it will come to some 30 to 50 ml, and that much blood can be transfused.
And we also take the fetoplacental blood volume into consideration when you
that is the reason we transfuse a very, very high hematocrit so as to not increase the volume. There are two different methods here. We do intravascular transfusion or intraperitoneal transfusion.
Yeah.
When it is intraperitoneal, at that time the volume really doesn't matter, because the fetus can absorb a lot of volume in the peritoneum, and it can get gradually reabsorbed into the fetal system. But if it is intravascular, then we cannot overload it. Once you start overloading it, you will have some response in the fetus which will show some adverse response, and you would stop there.
Dr. Sneha, can I ask a question to Dr. Chinmay?
I would like to ask Dr. Ashok Kumar sir to summarize what precautions we are supposed to take in such patients, what investigations, according to recent ways of management, how we should go ahead. Dr. Ashok Kumar, please.
Actually, Dr. Sneha, just one sec before Dr. Ashok Kumar goes on to the next, there's one very easy formula also for calculating the blood volume which you need to be transfused. Yes. And that is actually the weight of the fetus in grams multiplied by 0.02. And that would actually give you that is about, the 10% hematocrit, which it would raise. For instance, the baby's weight is say 1,000 grams. So you multiply it by 0.02, it would mean, it's just about 10. So 10 ml, and that would raise the hematocrit by 10%. So that's one easy way also. Otherwise, the other one is the one which Dr. Chinmay mentioned, the target hematocrit minus the initial divided by all that.
Yes. Thank you so much, Dr. Pragya. Dr. Ashok Kumar, sir, please.
Yeah, thank you very much. Am I audible?
Yes.
Yeah. Thank you, Dr. Lakshmi and Dr. Sneha, for this panel interaction. See, in this case, as Dr. Chinmay and my other co-panelists have also told, ICT is positive and amniocentesis is done, and which values are in zone 2. Actually, amniocentesis now is not in the protocol somewhere because of this problem of getting this delta OD. See, when we were the resident, we used to get delta OD in pharmacology lab, but now these labs and the facilities are not available mostly. So, and non-invasive investigation, peak systolic Doppler study have come in the middle cerebral artery. So, but suppose if in this case amniocentesis has been done and it shows that it is in zone 2, and after that it shows that hematocrit is around 30%. That means after amniocentesis they found it is in zone 2. Probably it was in the upper zone 2, so that they have managed it with the chordosynthesis, and there they found that hematocrit is around 30%. So when hematocrit is around 30, if they say that if it is less than 30, then it is an indication for transfusion. And in this patient, because she is at 26 weeks and the baby is at this moment preterm, so idea is to prolong the pregnancy as far as possible to get the maturity of the baby and to improve the gestational age. So plan is for intrauterine transfusion, and Dr. Chinmay has correctly said that how to transfuse and when to transfuse. And after that, I think I will not go for the amniocentesis, one transfusion, then I will monitor the patient with the peak systolic velocity of middle cerebral artery. And I will keep on doing this every weekly. And if again it is rising, because that will tell us whether the fetal anemia is setting in, because whatever you have transfused, if it is being consumed and then baby is going into fetal anemia, then probably that will, and if the values are becoming higher, then probably again we will need to transfuse the baby. So that way we will monitor not by repeat amniocentesis. And obviously along with that, we will do ultrasonography also to see the well-being of the baby, as well as we will look for the early signs of hydrops in the baby. It is said that we should correct the anemia before signs of hydrops develop, because then it becomes too late and the outcome is not very good. So we should not wait for the hydrops to appear. Rather, before that, we should keep on transfusing the baby. And our purpose and our main motto is that we reach around 35 weeks of pregnancy, because after that, peak systolic velocity measurements have very high false positivity. So we cannot go further with that investigation. And we are pretty sure that by around 35 or before that we transfuse the baby, then probably 1 or 2 weeks will also go. So by 36 weeks or by more than 35 weeks, baby is mature enough to survive outside. So after that, we can plan her delivery, and that way we can have a good outcome.
Meanwhile, we can give her the antenatal steroid.
Obviously, steroid is always a must in these patients. And see, we should not be too greedy that we should prolong the pregnancy as far as 37, 38. That should not be our target. Our target is,
34
yes.
weeks, I think, should be enough for this patient who has presented so early.
Yes.
With such high titers. So
Because,
that
yeah.
So
Because it is very difficult to reach up to 35 in these patients, because repeated transfusion and development of anemia, these babies start developing features of hydrop. So even if we cross 32 weeks, I think that is also good enough to terminate the pregnancy. It depends on the individualized patient history and all those things, and how the patient is progressing with the our biophysical profile and Doppler studies. And
the level of fetal care or NICU that is available. For example, if it's 32 weeks, sir, if it's 32 weeks and there is no facility for doing a fetal transfusion, it might be sensible to deliver and do neonatal transfusion.
It is both. To Dr. Chinmay. Dr. Chinmay.
Yes, ma'am.
For the benefit of all of us and the audience, I would be really happy if you would tell us how the MCA is, taken. The middle cerebral artery, how is it taken the peak systolic velocity? Because the size of the gate and the direction of the probe, these all make a lot of difference, because I've seen that a lot of inter-observer discrepancies are also there. Would you throw some light on that?
That's a very important point, because it's a very, very important marker, and the marker has to be done correctly for that to be allocated that importance. So as you rightly said, this is a measurement of velocity. Normally in Dopplers, we do indices which are like ratios of each other, and in that the numerator and denominator can compensate for each other. So the direction of the blood flow may not be so important when you're doing an index. But when you do a middle cerebral artery peak systolic velocity, the direction of the blood flow to be measured is very important, because if you remember the Doppler formula, the blood flow is Fd cos theta. Cos theta is the angle. So when cos is 0, theta is, when the theta is 0, the cos theta is 1. So you get the best measurement if your Doppler is in line with the flow of the vessel. And that is exactly why MCA is chosen. Because you see, whenever there is fetal anemia, all the blood vessels in the fetus will have hyperdynamic circulation. But why MCA is chosen? Because when you look at the BPD, you get the MCA in a orientation that you can place a Doppler gate exactly parallel to the flow of the vessel. And the gate is expected to be
that because sometimes our sonologists make that mistake. They over-record it, or they do not inform correctly. And we as obstetricians should know how to look at that graph.
So there is a circle of Willis in the fetal brain, and then when the middle cerebral artery starts, your Doppler gate should be at the junction of the proximal 1/3 and distal 2/3 of the vessel, and the angle should be exactly along the vessel, and the gate should be around 2 to 3 millimeter. So if you measure it like that, we get a peak systolic velocity correct.
I have
one more thing.
I have a doubt for Ashok Kumar.
No, just one more thing. Just one is that the baby should be quiet when you're doing peak systolic
Absolutely.
flow,
Any
Yes,
doctor,
no
yes.
breathing movements, no fetal movements and all that. Otherwise,
And
you won't
excessive
be able
pressure
to
also
do.
should be avoided,
Yeah.
because when you put too much pressure, you get no diastolic flow there.
And you have to take several measurements. You have to take several measurements, and then you take the peak of all the measurements which you have taken.
How do
Thank
you
you.
ensure this?
Yes, Dr. Charmila.
Sir, I read about a protocol like in a very early second trimester immunized fetus where you can give plasma, do plasmapheresis and then give intravenous immunoglobulin. Is
Yes.
there a place for that?
No,
Exactly.
yes.
In fact, in the case, we had one situation where the titers are above 1 in 256. So, what is the role for IV immunoglobulin for
No,
this?
plasma. They said they give 3 times, do plasmapheresis 3 times in a week, and then give intravenous immunoglobulin
It's
every
a bit
15 days.
theoretical as of now, ma'am, because it first of all, cost is very prohibitive. To do plasmapheresis, cost is a very prohibitive
Also
factor.
IVIG.
And IVIG is also available. There are
Very expensive.
studies where this has been done in India. Also, certain centers they've done it under trial conditions. But to offer it to a routine population, the cost and the follow up that is required is extremely intensive. But there is a role. And in fact,
See,
that plasmapheresis may be attempted before she gets pregnant. Suppose there's a woman who's having repeated hydrops because of very high titers of anti-D. Then you can do it in the interval period so that you clean her
Yes.
system before she
One
conceives
who is
next.
already sensitized and has.
What I
Dr.
have seen,
Charmila.
because
Yes.
Yes, sir.
we are
Yes, sir.
referring our patients to All India Institute who have a very robust program. So, although in the private sectors, the consultants would offer IVIG for previously immunized pregnancy, but the AIMS department is very particular about intrauterine transfusions and monitoring rather than going in for IVIG. I mean, according to them, it's far better to do IUTs and get safer,
It's
gestational age
because
and weight
IUT is a more
rather than IVIG.
well-established treatment, and
IVIG does
I,
not
I'm,
have
I'm,
any.
madam, I'm talking about a baby which is very, very small.
See,
even
Dr.
before your
Dr.
second
Charmila,
trimester. Yes, sir.
I will answer
Yes,
you.
sir. Yes.
Yeah. See, as everyone has told that, yes, IUT, we have a lot more experience, lot more data is available. IVIG, actually, and plasma exchange, actually, they have been done, and there are a lot of studies from AIMS, Dr. Deka studies are there, and they have found it useful. The situation where it is useful is in early pregnancy, where they're very high titers, and you want to save pregnancy. See, lady has so many lost her babies earlier because of RH. So when the titers are very high, or you don't have the time to do the chordocentesis, that means before 20 weeks comfortably. After that, it is easy. Technically, it is easy to do the chordocentesis. So in those situations, basically, you want to buy time so that you reach that stage where you can do IUT.
IUT,
right?
That's
so
what I wanted.
Before that, if you find very high titers and affected baby by your PSV and all these, in those situations, yes, IVIG can be given, and it is being given. These are the real indication basically to give IVIG, because we don't have any other answer for in those situations.
Maybe just to buy time to.
So in those situations, we give IVIG, and we can do plasma exchange also, because these are the things which are the only possibilities to improve the outcome. And once you reach that gestational age, and then you can start doing uterine transfusion. And there are lot good many papers and studies from India on these, and obviously AIMS was the pioneer in these type of studies.
Well, I mean, before 18 weeks, I mean, because you're not going to do fetal blood transfusion, some people would actually go for intraperitoneal transfusion.
Yes.
That is also one way, of salvaging the baby.
Yes.
But, it's just that, there's no, when you're going for intraperitoneal transfusion, the only problem is that you don't have days to know the pre-transfusion hemoglobin or post-transfusion. So usually you aim at a higher hematocrit. Like, normally if we are going for intrauterine, you would aim for a hematocrit of 40 to 50%. Whereas for intraperitoneal, you would aim for a hematocrit of about 60%. But people are going for intraperitoneal transfusion even now, if the baby is less than 20 weeks of gestation.
So Dr. Charmila,
one very
Dr. Charmila,
basic thing.
yes,
Yes, sir.
because see, once the lady has previously very bad obstetric history because of RH isoimmunization, in the current index pregnancy, they will come early to you.
Yes.
They will come in the early first trimester or middle of the first trimester. So what to do? And you find very high titers of, and in view of the previous history, like before 13 weeks or in the first trimester or around first and second trimester, what you do? So you have the option of IVIG. So those are the real situation where, challenging situation where you can give IVIG.
Yes. Ma'am, two basic points I wanted to say. First of all, every pregnant woman, we must do the blood group RH at booking. That's something which is actually not happening. I mean, it's a very MBBS level teaching, but we have patients who are referred for amniocentesis.
Dr. Chinmay, I would go ahead and say it should be a part of preconception counseling.
Absolutely, ideally, but at least not after IVF. They should not have their blood group checked after IVF, which is happening sometimes.
But Dr. Chinmay,
yes,
Dr. Chinmay, HB and blood group and urine albumin sugar, these are the few mandatory investigation for any pregnant lady wherever she is.
Sir, I don't do routine obstetrics. Every year, 30 to 40 blood groups are tested here for women who are referred for amniocentesis for high risk double market test. Because we don't do amniocentesis before checking. In fact, I don't scan women before we check the blood group. So some people go back because they are not willing to do the test, but it's surprising. That's one thing. Second thing, sir,
it's tragic that girls get MTPs done or they take the pills. They've had a history of abortion and they don't have their blood
That's
groups.
exactly what I'm saying. So every pregnant woman with a rhesus negative.
To listen to me what I'm saying. If you had seen my presentation, at least 3 of the 6 cases are mentioning that the blood group was not known and she delivered or aborted somewhere, and that's the reason it's not received, not diagnosed RH negative even till today. These are the facts. These are the facts.
You are very right, Dr. Sneha.
We should do an ICT for every rhesus negative woman, even if she's a primary gravida, because they may be immunized for any other atypical antibodies, or she may have had history of blood transfusions, which we often forget to take. So doing an ICT absolves us of all those problems.
And grandmother's scary. Grandmother's scary.
Negative mother was in the womb of an RH positive mom.
Yeah.
So she could have been immunized since birth. So we have to keep these things in mind.
In the discussion, I had mentioned that there are patients who, just conceive, miss her period, and within few days they abort and they don't even take the notice of this pregnancy. We call it as subclinical abortions. So subclinical pregnancy. These are the things which happen. I had personally faced one patient who has had MTP when she was unmarried, and she was RH negative. That was medical abortion somewhere, and now she landed up with the first pregnancy after marriage, where she's telling this is primary gravida, and now she is sensitized with higher titers.
So if we just do an ICT for all negative women, we are absolved of that responsibility.
Yes.
The other most important thing about failure of our anti-D protocols is that anti-D is often given in gluteal, whereas anti-D should always be given in the deltoid, which is not educated to all the perinatal administrators.
So with all our expert panelists, the fetal medicine experts, and so many academicians here, the expert obstetrician, my message very clear and very simple, that we must do the basic investigations before pregnancy, that is in the preconception counseling. We must do minimum baseline investigation of CBC, blood group and RH, and if RH negative ICT, and definitely OGCT as we are doing as a routine, universal screening for diabetes. And of course, whenever we are having any patient of pregnancy, abortion, we must inquire in detail regarding her past clinical or subclinical pregnancy or abortion. And that is why, even though you all are expert talking about the advanced technologies, we are here to face the Indian population at the very basic level, and we must tell them that blood group and RH type is so important, and because of their negligence, not us, because of their negligence, they can land up into such high morbidity and mortality of the babies. And that is why our message should be that they have to follow the baseline rules of obstetrics, that they should have at least the baseline investigation done before pregnancy or at least at the first visit of antenatal care. So I thank you all of you.
Thank you.
Yeah.
Thank
Yeah,
you,
just
Sneha. Thank you, Lakshmi
there
ma'am.
are many questions. No, you are not excused. Please. I mean, it was a fantastic deliberation on RH isoimmunization, moderated by Sneha, and excellent expert inputs by Chinmay, Charmila, Mitra, Pradya, Dr. Ashok. You are not supposed to leave. And Rashmi Kahar, please stay here. There are a lot many questions for you. But first, I am taking just 4 or 5 questions which are there on gestational diabetes. Milind, are you with me? Milind? Milind has just minimized and has gone. And Chamila and you all would have to answer the gestational diabetes questions as well. Milind, you can join and you can answer those questions. The first 2 questions are on the screen. I am very clear in my talk that DIPSI and Government of India is recommending the one-step OGTT. You just give 75 gram glucose to this mother. She has to take it in 300 ml of water. Drink it in 5 to 10 minutes and you do a 2-hour blood glucose, and if value is more than 140, you are labeling her as a case of GDM.
Yes.
So these are all 2 to 3 questions based on screening. Now, Milind, you can answer what is the dose of glyburide.
Before
that, Lakshmi.
Gestational and gestational diabetes, and what is the dose?
Yeah, before that, Lakshmi, I just wanted to add, because what I found, people always get confused if the obesity is, more than 140, what to be done next. And then people don't understand that one need to definitely subject her for complete glucose tolerance test to decide what actually needs to be done further. Regarding the oral, actually the anti-diabetics, except metformin, we never tried actually other oral anti-diabetics.
As a gynecologist, I have also not given glyburide. We
Exactly,
recommend the gynecologist. I just want to add to Milind, whenever you are doing full OGTT, please don't forget to add HbA1c, because every time the gynecologist asks me, Madam, tell me what is the HbA1c so that I can decide the proper management for this patient. So we always
and even
forget
HbA1c has to be done HPLC method. Again, that is very important, because otherwise again the results are little, not very comparable. So better to do it by HPLC so that we can decide everything, whether we can manage her with diabetic diet or whether we need to give her insulin. So that decision making is very clear with the help of that HbA1c. Correct. Yeah. So I think this regarding that oral anti-diabetic, let us ask someone if anyone is having an experience of that glucose.
Have you given glyburide? Anyone? Glyburide have you used?
Glyburide 2.5 milligram.
OD, BD?
OD.
It works.
And titrate the blood sugar.
It works well.
It works well, but more experiences with the metformin.
Yes.
Yeah, exactly.
One thing.
It is on metformin only. You can answer.
No, I just wanted to add some. I mean, actually, in fact, even I have a doubt. Metformin is one of my favorite drugs, in pregnancy.
Yes.
And especially, just like you, Dr. Lakshmi, my main practice is also infertility. And all these PCOS patients, once I've put them on metformin, they conceive on metformin. And actually, I let them continue throughout pregnancy. And what happens that, then rarely I've had to use insulin for these women. Now, what happened that recently there was a program of DIPSI with Patna Obs and Gynae Society, which I couldn't attend. But, I was told that what they were saying, that under 20 weeks, they are not recommending metformin. And after 20 weeks, you can give metformin. That's what they were saying is the latest. But I did not attend that program, so I'm not very sure, because I have been using metformin throughout pregnancy. So does anyone want to comment on that? Is it okay if I'm continuing throughout, or is there something latest that,
Madam, actually,
just a minute. Ashok, just a minute. We all are infertility specialists, and we do put our patients on metformin even pre-conception, even before stimulation, and we do continue right from the first trimester till she delivers. Yes, Dr. Ashok, you can share your experience.
No, see, it is all right in PCO and in infertile, in these patients, metformin is there, and when patient conceives, we continue with the metformin only, so that first trimester is taken care, and then if then she is not diabetic, then you stop it. Otherwise, you can continue these things in pregnancy also, so that the sugars are taken care. But that statement which Madam has told about, probably it is generated that oral anti-diabetic, actually it is written in the literature also, that long-term effects are not well known. What is the effect in the baby and how they will behave? So keeping that in mind, there are some reservation in the literature also, whether to use oral hypoglycemic in pregnancy or not, or in the early part of the pregnancy or not. So there are some hesitation about the use of oral anti-diabetic drugs. But for India and for low resource setting, it is very well written also that oral hypoglycemic agent is a first choice because of very easily available, cheap, no storage formalities are required as we do for insulin, and it is obviously it is taken orally, so more acceptable, and compliance will be there. So low resource settings and low resource countries, obviously oral drugs are first line.
Even RCOG guidelines, they say you use metformin as first line.
That is what I am saying, madam. The statement which you made, probably the reservation is about the safety of the.
There's one practical point, ma'am. Like as Lakshmi madam said, in a fertility patient, when you continue, we find that in spite of metformin, they still become GDMs. Yes, it doesn't totally prevent the formation, the development of GDM. It happens. GDM develops, and then the patient sometimes goes on to insulin also to control the sugars. Yes. So metformin may not be preventive for everybody to prevent a GDM in pregnancy.
May I mention one point, Dr. Lakshmi? Metformin, yes. Just because metformin does not mean that she is exempted from developing GDM. Yeah. We have to monitor as usual. I mean, as it is, Charmila, our IVF patients are already high risk. They are always more than 30-35 years of age. So they do have the increased chance of developing GDM, whether they are on metformin or they are not on metformin. So they have to be followed very religiously, very meticulously throughout their 9 months, starting from their first antenatal visit.
It's so just that, the
one point, Dr. Lakshmi, I wanted to bring to your notice that even though we say that we do a 2 hours single step 75 gram glucose, when we try and translate it actually to the patients in the first trimester or when at the time of booking, it's not an easy job to make the patient drink. So what I have started doing, I don't know now, I'm just sharing that at the first instance, I do HbA1c. So, I mean, like for me, patients can afford, I know that cannot be a guideline, but like we find practical difficulties in translating. So at 28 weeks, it's a mandatory for the patient to do the 75 gram glucose 2 hours. But at booking, I do HbA1c. Just to tell you that actually in translating the real guidelines into practice, sometimes we may have to change. So I just want to share that.
Can I make a comment on that? Can I make a comment on that?
You can participate in the discussion. Meena, you can unmute yourself. Meena, if you are there, please join us in the discussions. Yes.
May I take part in the
in continuation with Dr. Mitra, see, we also do.
Orange wala bhi tha na?
Yeah. Am I audible?
Yes. Yes, very much.
Okay. Now, see, in continuation with Dr. Mitra, what she says is definitely there is a point in that, because we also do the same. We do HB electrophoresis by HPLC method.
That's for HbA1c.
Whereby we get dual report. We get structured report of HbA1c. So in very less cost, we get two of getting structure as well as knowing about our HbA1c, the baseline. And eventually, as the person develops GDM, very true, it is very easy to follow it up that.
Dr. Gangadhar, you want to add something? Yeah, please, your expert comments.
Yes, ma'am. So now there is a lot of discussions about this HbA1c and oral hypoglycemic agents. Let me tell the basic thing that we have learned and we are teaching also. that the time when the mother should be euglycemic, most important time is peri-implantation period. Remember this, peri-implantation period. If in that period the blood sugar is not normal, then there is chance of increased incidence of congenital anomalies. So therefore, that period should be almost euglycemic. That's number one. So how to make her euglycemic? Either premarital or preconceptional counseling. Next is what is the most ideal? The gold standard is insulin, but we can go for oral hypoglycemic, either metformin or glyburide. Glyburide is equivalent to the action of the insulin. So that is, as Dr. Ashok said, that 2.5 milligram 1 hour before breakfast. That should be continued like this. So that is about this.
Yes.
Can
There
I
is
can
one
I
question.
can I
Kumar,
add
you can
something here?
answer. Yeah, please. Ashok, yes.
Yes. In response to Dr. Mitra's, see, the national guideline or DIPSI guideline says that your first challenge should be as early as possible in the pregnancy, at the first visit. So it may be in the first trimester also. Yes, there might be problem in some patients of taking 75 gram of glucose, but we can counsel the patient that she can take it with lemon and she can drink it slowly over a period of 10 minutes. Then most of the time we are successful in getting the test. If we are not able to get the test successfully, we may delay it by not by up to 28 weeks. So 28 weeks is the time when we have to repeat the test. If first test is normal, then 24 to 28 weeks the time to repeat the test in the patients who have normal the 75 gram DIPSI test at the first visit. So first visit we have to do it as early as possible, maybe in the first trimester, or if she's not able to tolerate it with the vomiting, then maybe as soon as she settles down, by that time we should be able to do it. That is the general thing or the recommendation by the Government of India.
And I will go with Ashok because he is working with Government of India, so his words are taken as final. Very well summarized, Ashok. Meena, you want to add something?
No,
Or you
and
can
one
answer?
more, Dr. Lakshmi, I just want all these things that we are talking, actually the FOXY guidelines on screening in pregnancy, which were actually part of this TOG conclave, a few years ago. It all gives all that, even going to RHIC immunization, doing the blood group and, what Dr. Ashok mentioned about, screening in pregnancy, doing it initially and then at 28 weeks. It's all there in the FOXY guidelines also in screening in pregnancy.
Because Pragya, basically FOXY endorsed the DIPSI and Government of India guidelines on GDM. So FOXY has not deviated a bit from these guidelines. So basically the DIPSI, Government of India and FOXY guidelines are same. Ashok, just answer this question. If a patient is having GDM with PIH, can metformin be given?
Pardon, madam?
PIH. GDM with PIH.
Yes.
Yes. And please, can somebody tell some broad guidelines about insulin in cases of GDM? Meena, you would like to volunteer? Insulin in cases of GDM.
Yeah, you already mentioned, though it's the first line of the drug of choice. These days, we're also going for metformin after the exercise and diet control. Insulin would be the non-controversial thing because it's been tried and tested, and you can control over it. Another thing that I wanted to add over the last discussion that was going on is sometimes even once we've tested, but on a examination we find that the baby is macrosomic or there's polyhydramnios. I think that is a time we should really look whether our test is, we need to repeat our test even though we've gone for the screening tests. So that is one thing I just wanted to add. And sometimes
we normally do that. We normally do that if there's polyhydramnias.
Yeah, because and also before giving betamethasone, because these days we are, it's the message has gone home that any risk of preterm and one would give betamethasone. So before that, because we've had patients where patient would go into ketoacidosis, even her first trimester, her last blood sugar was normal.
Dr. Lakshmi, Dr. Lakshmi, can I add about insulin? Can I add about insulin?
Dr. Mitra,
Yes.
congratulations. You and
Thank
Dr.
you.
Ashok, two new winners here.
Yes.
Dr. Lakshmi,
Then
can I
we
add about
to
use of
ICT
insulin if you will allow me?
Yes, madam.
Yes, yes.
I've had a lot of patients who are juvenile diabetics, and in association with an endocrinologist, what we do is that we have to educate. Normally, we do a 4 times blood sugar, but here I educate the patient to buy a glucometer, learn the technique themselves, and do a 5 or a 7 times. So we do it fasting, then pre and post breakfast, lunch, dinner, and then the next day morning fasting also. So they have a whole spectrum. We educate them. And what I have found that the best thing is to educate the patient about the timings and the portions of her diet very, very religiously. And the easiest way to control with insulin is to put her on plain insulin and use sliding scale. So along with an endocrinologist, the patient and us, together we can actually individualize the insulin requirement of that patient, which obviously, like if we do a blanket thing that 1:2 ratio and 2/3 dose in the morning, 1/3 in the night, I found that unless I sit down and make the diet chart, the timings also, that this is the time for your breakfast, this is the time for your lunch, this is time for your dinner. Unless I do it, I don't find that the blood sugars will be controlled properly and it goes haywire. But if we are a little bit meticulous along with endocrinologists and go with this, and plain insulin is very, very easy to manage in pregnancy, because then we know that the duration of action will be 6 hours. This is the amount of food she's taking. If you do pre and post blood sugars, then the next time doses can be easily adjusted. So this is a practical thing I have found very useful. Thank you.
Madam,
That is
should I
what
respond to
I
your
did.
queries? Madam, should I
Yes,
respond to your
Ashok.
query? Yeah.
Yeah,
You
just
asked
a minute.
about
That is what
you
I said. It has to be a individualized treatment, because insulin you can't have general recommendations. What should be the dose? But you have beautifully given the general guidelines. And I know you are from a small place, so the gynecologist has to step in as a dietitian. You have to monitor the insulin. But at bigger, we have the luxury of referring them to endocrinologists, and then they monitor the blood sugar levels for us. Yes, Dr.
No,
Ashok, please.
I have an endocrinologist also, and he is also there, and me. But both of us, we actually, the main crux is that if you make the timetable of the patient, that this will be your time of breakfast, this will be time of lunch, and we tell them that this much is the portion, this is the calories, and we give them little bit of options, and they come on. I mean, I've seen the least educated patients also respond very nicely.
Yes,
But
yes,
we have to
Ashok.
be very careful.
Yeah, I just wanted to tell you about the insulin, when to give. See, usually now evidence says that metformin or oral hypoglycemic and insulin have equal efficacy. So it is your choice. You want to start with insulin or with the oral. If you want to start with oral hypoglycemic, if your sugars are not controlled with that, that is well known that you have to add on to the insulin. That is one thing. But there are a few specific criteria in which you don't have to give oral hypoglycemic. You have to straight away start with the insulin. Those are like when there is a macrosomia or evidence of polyhydramnions. When your fasting blood sugars are high, they are not controlled. In these situations, it is very clearly written that you have to start with insulin. Then probably oral hypoglycemic will not work. And insulin will better control these situations.
So friends, tighten your belts. Still you are not finished. Still we are having more than 400 delegates who are listening to your deliberations with apt attention. And now from GDM we are moving to RH isoimmunization, because I mean participants have really listened to your deliberation, and that is why we have generated so many questions. So now I am starting with the first question. If ICT is positive, do we need to bother about the husband's zygosity? Charmila? ICT is positive. Now at this stage, are we bothered about husband's zygosity?
May not be helpful at all because already she's immunized. You have to manage it pregnancy at that point of time.
No, Dr. Sharmila. We should still know the zygosity of the husband because if he's heterozygous and it was the last pregnancy because of which the patient has had RH positive, and this time if she's carrying RH negative, if the husband is heterozygous, so ICT may be positive at the beginning, but if the baby is RH negative, then the titers won't rise. So if we do the zygosity of the husband, it will always be helpful. I would say that.
You may miss out on certain immunization pregnancies if you are going.
I've had a patient with similar history. Her husband was RH positive, patient was RH negative. First baby, everything fine. Second baby started with RH, anti-ICT positive, and actually the titers remained the same. And at the end, the baby was RH negative.
It can happen once in a while, ma'am, but that is not a protocol. You have to manage it like an immunized pregnancy.
More than the husband's zygosity, I think it is important to do a 11-cell panel on the ICT to see what all antigens is she immunized for.
The next question is in continuation with this only. Now ICT is positive. Is amniocentesis recommended?
No.
Why? That's what I was
MSV,
saying at the
you
beginning,
have,
that it's an
TSV.
obsolete thing, really. Going for amniocentesis, we all go for middle cerebral artery peak systolic flow velocity.
Forgotten for almost 15 years now.
Yeah.
Stopped.
So I feel that we shouldn't have discussed it so much.
Amniocentesis, yes.
Sent a wrong message.
So the experts have given a clear-cut message that amniocentesis is we don't do. Do we give NTD even after delivery, even if patient is ICT positive? Does it give slightest protection if it is ICT positive? What is the prophylactic dose antenatally?
Prophylactic
300, always 300. Because 50 and 300 almost cost the same. There's no point in changing the product.
Okay. If patient has
it's not only the cost, it's that in India, you mostly have 300 micrograms.
50 is there, madam. 50 is there.
Yeah.
No, it used to be 150 are also there.
Yeah. Actually, it used to be there, Chamila, but that, that 50, that microgram, you hardly is available now. So, but the sponsors, in fact, of this program, which are, Bharat Serum. So those people, they have this 300, and as Dr. Chinmay said, they have the lower dose, it's 150 Proclone. So,
is ICT recommended before giving NTD when patient has got retroplacental bleed?
What?
It's better.
Ideally, yes.
Ideally, it's better to check.
Then, ma'am, if you are giving an NTD, after that her ICT will come positive. If you have done an ICT before that, then you know that this is the reason now it has come positive.
Yes.
Because if you don't have a prior negative ICT, you don't know when she was when this isoimmunization has happened.
I think you all have answered, but you can summarize for the benefit of this Dr. Niranjan Nayak. How do you calculate the dose of NTD for RH negative mothers after delivery? Does it depend on the amount of fetal-maternal hemorrhage?
Yes, it depends on the amount.
I can answer that.
Yes, ma'am.
Normally, what they say, that 300 micrograms is enough, to cover for 30 mils of whole fetal blood. Or you can say 15 ml of fetal RBCs. So normally, the fetal-maternal hemorrhage, that amount is quite a large amount. Normally, in an average pregnancy, the fetal-maternal hemorrhage, it would just be about 4 ml or so. So, it would actually cover that 300 micrograms. But, if you're really suspecting that there's a chance of a high fetal-maternal hemorrhage, then in those cases, then you go for this Rosette test or Clay-Betke test to actually calculate the extra amount of antibody which you need to give to this patient. But really, honestly, in India, Clay-Betke test is not really popular. I mean, when I was in England, we were all going for that test routinely. But here,
in India, I think it depends on your pathologist. If they will support you, then they will give you the report. Because it's a simple test. It's a simple acetylation test.
No, can I ask what is the experience of our panelist who is doing which one to find out the fetal-maternal hemorrhage? See, I don't have
Theoretically we know,
any.
but nobody is
So
doing it.
sometimes we have
We
taken
know the
the
clear
help of
bed
the
test.
pathologist to just make sure that what we have given, like the expected feto-maternal hemorrhage is not more than 30 ml. So that much, we have not had a situation so far where the expected feto-maternal hemorrhage is more than 30 ml. But
So, but we
individual
are
pathologists have done it.
clinically we are not doing any test. That is what the message is, or we are
Clinically, sir,
doing
we
some
can do
tests.
flow cytometry. Flow cytometry is possible.
Who is doing flow
Sir,
cytometry?
in the transfusion units, we can do the transplant units. They have.
Are you doing in your practice?
If necessary, I can do. I have the
You
facility.
can do. Dr.
Yes.
Charmila, anything
I can do. I can do. Abruptio placentas I always do. Abruptio with RH negative.
You are doing flow cytometry.
Flow cytometry.
Okay.
Or
So
are you
flow
using the
cytometry is
Clehor
available.
Betke test?
Can I
Clehor
go to
Betke,
next?
I have had pathologists and the blood bank people who have helped. They have made slides and they have seen and they have told us something, but we have not been able to charge the patient ever because it was not
Okay.
in the list of services. It was done as an academic process.
Passion of all the expert panelists is commendable, huh? Just have more patience. Is it necessary to do indirect Coombs test for multi if they have taken NTD injection for previous delivery for Dr. Anupama?
Yeah.
Always.
Yes.
Always.
Yes.
Always.
Can we give NTD at 28 weeks of gestation? Dr. Shakuntala Yadav wants to know.
You should.
That is the routine, ma'am. Like Dr. Sneha showed one slide, no, that there can be just silent isoimmunization. Some 6% in the first trimester, 13% in second trimester, and 29% in third trimester. So, to prevent that, routine antenatal anti-D is given according to some bodies. There is no universal guideline for that. RCOG suggests giving it at 28 and 34.
ACOG also says that, and you should remember, because cell-free fetal DNA we are checking, we know that the DNA is getting into the mother's circulation. So there's always a theoretical risk of the mother getting immunized. So it's always better if you give a 28.
Guideline even by Foxy that we should give antenatal anti-D. We are giving it for so many years now. And prophylactic anti-D.
But again, it's depending on a system-to-system process.
Resources.
If you don't have it, if you are unable to give it, I think it's a good idea to do an ICT at 28 weeks to just double check that she's not already isomimmunized.
Yeah. Dr. Varsha Ghale wants to know MTP pills patient, is it necessary to give half dose if you are done medical abortion?
Cost doesn't matter at all. Sure. We were giving 150, but now I'm giving 300 itself.
When to give this NTD after abortion?
When the mifeprin is given.
No, but if you have 150 available and it's just under 20 weeks, you might as well give 150. There's no point in giving 300.
So what Charmila ma'am is saying, because the cost is not different, she wants to give a bigger dose.
So err on the safer side always. More of
err on the side of caution.
I was giving 150
actually. What
now
both of you are right.
Yeah.
All the first trimester mishaps, you have to give NTD, whether it is vesicular mole, ectopic, MTP pill. But it is less than 5
repeatedly. That question comes repeatedly, but ma'am, by the time you prove it is vesicular mole, you would have crossed the time. By the time you get a histopathology of a complete mole or a partial mole or whatever, you would have crossed the time if you want to give it. So like Charmila ma'am said, it's better to err on the side of caution and give it.
Yes, but if the pregnancy
doesn't
is less
harm
than
her
5,
anyway.
If the pregnancy is less than 5 weeks and you are terminated by medical abortion.
These are all theoretical, ma'am. At the end of the day, if she gets isoimmunized,
yes.
5 weeks again. 5 weeks. If you see a miscarriage at 5 weeks, you don't know exactly unless you know the date of conception. So we don't know whether it is.
36 day of the conception, the fetal RBCs are there, and we have to give.
Dear participants, all the experts are very unanimous in giving you a clear-cut take-home message.
Let me confuse, ma'am. Let me confuse once. All of you. Should you give NTD if the woman is having a tubectomy?
Yes. Now, because now the she may get married
Maybe
again.
she wants IVF later.
Yeah.
More than vesicular mole, this is a question which confuses us. If she has a tubectomy, should you give her NTD or not?
Yes, I get the consent and don't
answer because the whole scenario has changed because I am into infertility practice. So I know these patients, they do remarry and they want to have another child. So it is better to be on the safer side and please be liberal in giving NTD rather than holding just for the sake of the cost. Patient will not mind it if you really counsel them properly. And as a doctor, if you say you have to take it, they will be more than happy to take an injection. Now,
Madam,
Recanalization also, madam.
Madam, you are all right in saying this, but the situation what sometimes we face in the government hospital, the poor patient has come and she undergone cesarean with the bilateral tubal ligation. That was her consent. So now the question is, she's so poor and sometimes hospital is not providing free of cost. So whether to buy more than 2,000 rupees and to spend and then to give the patient where she cannot have the money for the food also. So that is the big dilemma we face sometimes, and ethically or non-ethically, what to decide in those situations. Absolutely. So sometime we avoid giving then so answer may not be clear cut, depends on the situation.
So sir, we are assuming that she's so poor.
I want to say,
we are assuming that she's so poor that after that she can't afford IVF.
That's what I wanted to say. If she is going for IVF, she is going for NTD.
No, she is poor as of now. For her, we can't take decisions.
May I tell you?
Dr. Gangadhar, just a minute. We can't take decisions on her behalf, even if she is poor. I will document in the file that as a doctor I have advised. You never know, her situation might change after 5 years, 10 years. And she might be married to a rich guy. I mean, we really don't know. These are the patients. Hey, Dr. Ashok, I have seen these are the patients who get a lot of problems in case of complications or any future problems. Even though she is poor, but they are very well read, they understand everything. So if I would have been in your place, I will definitely counsel them. I will counsel the relatives. I will put it in the file that I have advised them, but they are reluctant to take or whatever. I mean, so that I am safe.
That is what all we do. But sometimes we have to face these situations.
We make them write a consent. We make them write the consent that they've been advised and they are not taking it, and they've been explained the consequences.
Because Dr. Ashok, in the future she might meet with an accident. She might need a blood transfusion.
That is the initial thing which Dr. Chinmay has. That is the initial thing that Dr. Chinmay has started. Yes, we should give NTD, but sometimes situation warrants some other way also. But we have to safeguard ourselves. Yes,
I perfectly understand, because we practice in private sector, so sometimes we are not used to seeing the scenarios which you see in the government setup. So these are entirely different, but still I will prefer that as a doctor we should be on the safer side. Yes. Sir, Gangadhar sir, you wanted to add. Dr. Gangadhar sir, please.
That is already being answered. That means in future you may need blood transfusion where it may be life saving. Therefore, that situation following accident or anything, any disease, where you need RH negative blood, but it is not available for life saving. So if you have missed this dose, then it is a precarious condition. Therefore, after tubectomy, it is always
yes.
So one point I can raise regarding this, madam. So is there any place of IUI or adoption in case of RH negative, RH isoimmunization? Suppose repeated isoimmunization, pregnancy loss is there.
Donor sperm.
So can you advise?
Donor sperm.
Yes, donor sperm, RH negative husband.
Surrogacy, donor sperm, all that can be options if she is not being able to treat.
They have their ethical barriers, sir.
Gangadhar sir, in this era of evidence-based medicine and so many litigations, as a treating clinician, I will offer her, I will counsel her what are her available treatment options, and based on her current situation, I will let couple choose what they want to go ahead. Like there are so many treatment options for every medical condition, but I will not take decisions on their behalf. So we will just offer them, counsel them, we will tell them the success rate, the cost, the procedure, and that is how we practice. Why MCA monitoring is not helpful after 36 weeks?
The false positive rates increase, ma'am.
That is what I told. Yes, I told. Yes, they increased to around.
So it's not reliable. That if you have
very high false positive rate. Very high.
I have a question
on false positive ICT and quantitative antibody measurements. False positive ICT.
False positive as in there may be an ICT positive for some other atypical antibody, not D antigen. So that can happen even in rhesus positive women. So sometimes you would see fetal anemia in rhesus positive women, and when you check, you get ICT positive because there's some other atypical red cell antibody there.
Amnestic
So false.
reaction.
Sorry, sir.
But whatever the antibody should not cause any hemolytic disease in the baby.
Yes.
So that has to be followed up with care.
By the fetal MCA. For everything, the final common pathway is fetal MCA.
Anemia should not happen.
In fetal anemia, what happens to umbilical artery Doppler? Charmila, now you are on anemia. In fetal anemia, what happens to umbilical artery Doppler?
I don't have any idea. Nothing.
No, nothing, because the reason, anemia will not cause changes. Umbilical artery Doppler is a Doppler flowing against placental resistance. So there is no change in that. The change is only in the systolic velocity.
The cardiac output increases, so the changes will happen in the cerebral circulation.
What does equivocal ICT
No, but I just want to add something. I just want to add something. But if you're if you're doing a fetal blood transfusion, but in the follow up, of this patient, you would be following her up with, even with the umbilical artery Dopplers.
Surveillance
it is part of the complete assessment. But in umbilical artery Doppler, what we are actually checking is the index, pulsatility index or resistive index. That will not change. However, if you actually look for theoretical purposes, let me say, if we are going and looking at the velocity of the blood flow in the umbilical vessel, that also might be higher. But then we can't get it because we can't get the vessel in the same, it's a coiled structure there. So all blood vessels of the fetus will have hyperdynamic circulation. That is the whole pathophysiology of anemia.
And in anemia, will be cerebral hypoxia. So preferentially the blood will be going to the brain, cerebral circulation. So that is the adaptive mechanism. So that is why we have high PSV. That is why we have high PSV in MCA.
Yeah. No, but the question that the person had asked whether umbilical artery Doppler will have any effect, the answer is no.
Not due to anemia alone.
Yeah.
Only few questions remaining. So just have some more patience, 5 to 10 minutes more. What does equivocal ICT means?
Neither positive nor negative. You are not sure whether it is positive or negative. So be a lab error sometimes.
Titers are very low.
It may be a lab error, so it is better to repeat it either in another lab or in the same lab after 2 weeks.
Dr. Ashok, Surekha Wankhede wants to know, do we have to increase metformin trimester wise?
No, it is not with the trimester wise. It is as per the blood sugars. It is as per the blood sugar profile of the patient. See, whenever we are on the patient, we advise them to do weekly profile if they are controlled. So according to that, we have to see the dose. And sometime if patient is unstable, we have to do daily blood sugar monitoring, and we have to see that more than 50% of the values are abnormal. Then only we increase the dose.
And it may not work beyond 1.5 to 2 grams.
Yes.
It doesn't work beyond
maximum dose is
2,000 milligrams.
2,000. Beyond that.
Yes. One last question. Patient is already on metformin 1000 grams. OGT 75 gram glucose load is done at 28 weeks and it is 145. Should we give MNT for 15 days and repeat OGT and then go for insulin? I mean, what will be your message for this, Dr. Vikranti Mure?
I think 15 days of MNT is better, and then
anyway, should be good, and monitor a little earlier because it's already 28 weeks of pregnancy. You don't want her to become a total more higher diabetic, which will cause a problem.
It may be other way around. When patient is on metformin, it is better to do the blood sugar fasting and PP to see
it's already metformin 1000 grams.
And increase it to 1.5,
and then depending on the values, you increase the dose.
I mean, one couldn't do for MNT because, the fact that she's on metformin already 1000 milligrams, it shows that earlier she would have gone for MNT and then after that metformin.
Yes.
No point in waiting, So I think she can.
Her MNT is not enough, that's all. She's not done it properly. She has to, because 145 is not a big difference between 140 and 145. So the thing is, she has to go on a better diet increase her metformin and check her blood sugar fasting and postprandial after a week to see whether she's controlled. And the target level should be maintained within that.
One last question. 28 weeks.
What?
Could not hear, madam.
Lakshmi ma'am, we can't hear you.
I think her net has
ICT positive. How to manage?
28 weeks.
ICT positive at 28 weeks.
Critical value has to be checked. Critical titers.
Which are the titers of the ICT?
28 weeks, second gravida, ICT positive.
Critical titer, madam.
First of all, you have to check that she has not taken anti-D in this pregnancy, because that is one of the common reasons for ICT to be positive. If she has not taken anti-D and ICT is positive, then once we have to do the titer and then follow up with MCA peak systolic velocity.
It is mentioned 28 weeks. So when she should have taken the...
Sir, by chance, sometimes some people have a trauma or some amniocentesis or something or the other, because of which an anti-D might have been given. So even sometimes after circlage, some people give anti-D to the Rh negative woman. So if by any reason she would have taken an anti-D in that pregnancy, that could be a reason for that being positive.
And they usually go doctor shopping.
It's
Every
just that
month
we
one
need to
doctor and one
remember-
would have given somewhere.
No. What we need to
Then by
remember that
titer
the
we can
half-life of half-life of anti-D is about 16 to 24 days, So that is important. So we need to know exactly when was she given. So that effect could have probably worn off by the time, she has come to you. So, and that actually could be as a result of sensitization. I mean,
Absolutely, ma'am. But sometimes we take that history because up to 6 weeks also that effect can be there.
Can be there.
And like madam said, they don't tell. They go from one doctor to another doctor. They don't say. So then we start a whole retinue of tests just to find out that it was a passive antibody.
So question is how to differentiate whether this rise in titer, this presence of the ICT is due to the injection that has been taken anti-D or it is isoimmunization. That is the problem.
If it is isoimmunized, it will either remain, the titers will either remain the same or they may increase. Whereas if it is passive thing, it will either remain the same or decrease.
So to repeat your titers, you have to repeat your titers or once in 2 weeks to find out whether it's increasing or plateauing at that level.
No, and plus the titers are very low. With passive immunization, the titers are very low.
And you will know that's increasing if it's active.
The lab people usually say that we think this is
passive.
So what is the correct thing is, if it is due to the anti-D injection, it can never rise to more than 1:4 dilution. So therefore, if it is more than 1:4 positive, it is taken that it is due to isoimmunization, not due to the injection of anti-D.
Yeah, that's what I'm saying, that they are very low titers.
Yes.
But
1:1 over to 1:4.
So just because you see 1:4, you cannot do it at that point of time. You have to check for the next titer value.
Yes,
that has to stay. Otherwise, with touches to 1:4, you can't say just because of an injection.
It might become 1:16 later
16 later on.
Yes, therefore that depends. That I'm telling. Okay.
Yes, sir. You want to say anything? Otherwise, I am just.
Just I want
Dr.
to
Lakshmi,
say,
please switch on your video. Please switch on your video.
Ma'am, video is on. I think there's a lag in her movements.
Okay.
Nagpur, it is raining heavily, so there is some problem with the network. Dr. Gangadhar, yes, the final concluding remarks from your side, please. Please go ahead, sir.
Final concluding remarks regarding diabetes is that for an obstetrician, 3 situations are nightmares for me. One is preterm labor, second is GDM with IUGR, third is GDM in labor where shoulder dystocia occurs. So clinically, I always am afraid of these 3 situations. So my
only 3
gynecologist that while you are dealing with any GDM case, please keep in mind these 3 situations which can either make you or break you. That's one. Regarding Rh isoimmunization, so one thing should be, as an obstetrician, we should carry that nobody should be taken as an absolute primate.
Yes.
So might be there is something, either premarital, extramarital, whatever it may be, or missed history. So therefore, don't get biased by the history. Always stick to your principle. So always follow the guidelines. Then only you will commit least mistakes. So these are the two things I want to take. Thank you, madam, for giving me this opportunity. So may Lord Jagannath bless you all. So I am too happy to join with Vidarbha. That was one of my dreams. One day I had told to Lakshmi madam and also Sneha madam that the earliest possible chance I will get, I will visit Vidarbha. So
virtually you are visiting Vidarbha. So first of all, thank you so much, Dr. Lakshmi, for the inviting. Thank you so much.
Just 30 seconds more. Just wait, Pradnya. Thank you so much, sir. Though it's a virtual visit, but we are honored by your visit to our Vidarbha ISOPAB. And I must appreciate the patience of all my experts, Charmila, Chinmay, Pragya, Ashok, Rashmi, Milind, and Dr. Gangadhar sir for waiting till last. And I mean, practically since last you answering the questions of all our participants. So thank you so much for participating as an expert in this webinar on high risk pregnancy. And I take this opportunity to thank all the participants also for staying with us till last and for your active participation in the webinar. So thank you all. Thank you so much.
Thank you
I
so
look
much.
forward to see you all again and some other forum. So thank you.
Thank
you. Thank you, Lakshmi.
Thank you.
Thank you so much for the
Thank you, madam,
opportunity.
for giving us the opportunity.
And thank you all the co-panelists. It was nice,
Meeting in virtually.
You I feel very nostalgic, because we've been together for 3 years, and Chinmay as well,
Yes.
And so thank you
Nice
so much,
to
Dr.
see you.
Lakshmi.
Actually,
I'm
after a
really
long time.
happy to see you again as a lively, vibrant Pragya, whom I know. I mean, you have really come out so well out of that
Yes.
personal illness, and I'm really happy to see you once again as my original Pragya.
Thank you.
Thank you so much, Lakshmi ma'am. Thank you, Sneha.
For coming out from that Government of India meeting and you for honoring our invite. Thank you so much, and thank you, Charmila, Chinmay, Rashmi, and Gangadhar sir. I mean, you really stayed till last. Thank you so much.